Good morning. This hearing will come to order. I want to welcome everyone to today's hearing titled Analyzing VA's Action to Prevent Legionnaire's Disease in Pittsburgh. I would also like to ask a unanimous consent that several of our Pennsylvania colleagues be allowed to join us here on the dais today to hear about an issue very specific to their constituents. Hearing no objection, so ordered. Today's hearing is based on a recent outbreak of Legionnaire's disease in the Pittsburgh VA Medical Center. At least 26 recent cases of Legionnaire's disease have been associated with the Pittsburgh VAMC. While VA has stated that 8 of these cases were definitely not contracted at their hospital, it has also stated that it cannot determine whether 16 of these cases were contracted at the hospital. VA contacted the CDC last fall to investigate the issue. The CDC's report, just released on Friday, not only determines that many veterans likely contracted Legionnaire's disease through the Pittsburgh VA healthcare system, but that tragically 5 veterans have died over the past 2 years from Legionnaire's disease acquired at the hospital. The CDC report paints a more complete picture, and it turns out that problems originated much earlier than the VA has stated and are much more widespread. While VA's public acknowledgement of Legionella bacteria in the water at Pittsburgh VAMC did not occur until November 2012, the subcommittee, in the course of its investigation, uncovered a great deal of evidence that officials at the Pittsburgh VAMC were aware of the serious problems with their water sterilization system well before this time. What's more, this outbreak was more than likely preventable. This event is rooted to the history of the Special Pathogens Lab that at one time was a hallmark of the Pittsburgh VAMC and the flagship of Legionella research across the globe. Its abrupt closure in 2006 under questionable circumstances was followed by a congressional hearing in 2008 that led to the exoneration of Dr. Stout and Dr. Yu, the lab's directors, and the admonition of VA. But the loss of the Special Pathogens Lab and the experts within it directly impacted VA on both a local and as well as on a national scale. According to VA's own documents, the Legionella protocol in place at Pittsburgh from 1997 to 2006 resulted in no hospital-acquired Legionnaire's disease. This protocol mandated testing copper-silver levels and Legionella testing every other month. How is it that a successful system is now blamed for the problems in Pittsburgh? VA also tells us that Legionella is a national problem. I agree that there should be a more comprehensive program with a single focal point. However, VA provided documents to the subcommittee stating that as of December 17, 2012, there have been only 5 Legionella cases across the entire VA healthcare system, and all 5 cases were community acquired. Even basic news reports tell us that these numbers are far from accurate. Does VA even know how many cases of Legionnaire's disease exist in its patients and where they could have originated? The recent CDC reports indicates VA either has no idea or is deliberately downplaying what actually happened. The deaths of 5 veterans and the many other cases of Legionnaire's disease are nothing to be downplayed. I understand that different agencies have different protocols for preventing and responding to Legionella bacteria. It is my wish that today's discussion and the recent outbreak in Pittsburgh can provide an opportunity for appropriate agencies to put forth a unified effort to establish a national framework on addressing Legionella. From that framework, local protocols can be put in place so that a local facility can respond appropriately. The subcommittee is not advocating for any one method of Legionella treatment. Just that whatever proven system is put in place be used correctly, regardless of the method. What happened in Pittsburgh could have been prevented, and veterans have unnecessarily paid the price. I look forward to a thoughtful discussion today on what VA officials knew about Legionella in the water at Pittsburgh VAMC, when they knew it, and what actions they took to address this serious problem in a responsible and timely manner. However, I am disappointed that, despite several requests to VA from the subcommittee, no one from the Pittsburgh VAMC who was there during the incident is here to deliver firsthand knowledge of events. Hopefully, the witnesses that are here today can, at the very least, recommit to the department following its own protocols and holding accountable those employees who failed to do so. I now yield to the ranking member for her opening statement.
Thank you, Mr. Chairman. Because they've already paid the price, we must fight for our veterans with all our might. Today, this subcommittee will examine the sufficiency and efficacy of the Veterans Health Administration's policies and protocols on the prevention of Legionnaire's disease. We will also scrutinize the actions and follow-up measures that the Department of Veterans Affairs took once it learned of the outbreak. In December 2012, we were informed by the VA that there had been an outbreak of Legionnaire's disease at the VA Pittsburgh healthcare system. The VA had identified a total of 29 cases of veterans with Legionella pneumonia, with 5 of those cases having originated in the hospital. I am sad to say that 5 patients have since died. Legionnaire's is a deadly disease. I'm sure everyone here would agree that we must ensure every precaution is taken to mitigate the risk of exposure, both for the veteran patients and employees. It is my understanding that the VA Office of Inspector General is not only reviewing the VA Pittsburgh healthcare system, but they have also begun a national review of Legionnaire's disease at Veterans Health Administration facilities. I look forward to reading both reports. Because of this unfortunate outbreak, our attention has been drawn to really focus on the sufficiency of the policies, protocols, and guidelines that are available to the VA medical facilities about the prevention of Legionella. In a recently released TRIP report on the Pittsburgh facilities, the Center for Disease Control reported that Pittsburgh had a large number of healthcare-associated Legionnaire's disease cases during 2011 and 2012, and widespread Legionella in the hospital's potable water system. I understand that Pittsburgh VA was recognized as the leader in Legionella research and was considered a model for control and prevention, even providing Legionella services for VA facilities nationwide. Indeed, they had no hospital-acquired cases from 1997 to 2006. In testimony, Dr. Stout, who established the program at Pittsburgh, attributes the recent outbreaks to inadequate Legionella testing of the water and inadequate monitoring for ionization levels. I'm troubled by this. If it turns out to be true, that means that the current outbreak could have been avoided had someone done their job properly. Further, it begs the question, when did Pittsburgh actually learn of Legionella in the water? What steps did they take to mitigate it? Did Pittsburgh alert the National Office of Legionella in the the National Office of the Legionella in the water? Why were patients and VA employees not notified earlier that a problem may have existed? Looking back, were the decisions that were made rational responses to a developing crisis? Finally, I would hope by the end of this hearing to come to a better understanding of what actually happened, when it happened, where failures occurred, and how we can fix it. With that, Mr. Chairman, I yield back.
Thank you, Ranking Member Kirkpatrick. I ask that all members waive their opening remarks as per committee's custom. However, I understand that one of our visiting colleagues, Congressman Doyle, is going to have to depart early, and since his constituents are directly impacted, I will yield 5 minutes to him for opening remarks. Mr. Doyle.
Thank you, Mr. Chairman, and I want to thank you and Ranking Member Kirkpatrick for allowing me to address the subcommittee and today's witnesses. I served on this committee for 6 years. The Veterans Affairs Committee is a great committee. As many of you know, I represent the city of Pittsburgh, and the events in the last several months have been of great concern to our community, myself included. As disturbing reports about the Legionella outbreak at the Pittsburgh VA began to break in the local media late last year, I, along with my colleague and friend Tim Murphy, contacted the Veterans Affairs Committee to request a hearing, and I'm extremely thankful to the committee's swift action on this issue. I want to start off by saying that in the 18 years that I have represented Pittsburgh in Congress, the Pittsburgh VA has been an asset to my community and my constituents. The VA, its doctors, its nurses, its volunteers serve our veterans with top-of-the-line care. I frequently speak to veterans in my district, and I constantly hear great stories from them about the care they receive at Pittsburgh VA. And as our soldiers return from tours abroad, providing the best care to those who have served our country has never been more critical. My father was a 100% service-connected disabled vet who received excellent care at Pittsburgh VA in the 50s and 60s. So we know firsthand as a family about the good care that comes from Pittsburgh VA, and I'm proud to represent the facility. But having said that, we're all here today with the same goal: to get to the bottom of a very clear failure of water testing and treatment at Pittsburgh VA. This tragic incident resulted in the death of at least one veteran and possibly 4 more at VA. This is simply unacceptable. It's my hope that today we can start getting some of the much needed answers. It is critical that Pittsburgh VA clarify, both for this committee and the victims' families, some of whom are here, exactly what happened. The questions must be answered. When did the VA know that there were unacceptable levels of Legionella bacteria in the water? What did they do about it once they knew? And was that response appropriate? And perhaps more importantly, was this an isolated incident, or does VA need to develop and mandate better standards for testing and treatment of water at its facilities across the country? I think these are relatively simple questions that we need answers to. It's my hope that not only do we leave here today with a greater understanding of the events as they occurred, but also with a plan to move forward. This tragic series of events makes clear that we need a better set of best practices when dealing with Legionella. Clearly, this is a regionally significant issue for southwestern Pennsylvania, and I hope that this committee and the testimony of these witnesses will help us move forward with a protocol to prevent future outbreaks in my region and across the country if it turns out that this isn't an isolated incident. Mr. Chairman, I apologize that my duties on Energy and Commerce require me to be at a hearing which has started also at 10 o'clock, but I know that my colleague Tim Murphy is here to ask questions on both of our behalfs. My staff will be staying here for the entire hearing. I look forward to finding out what we learned here today and reviewing what the subcommittee learns. And I want to just close by once again, Mr. Chairman, thanking you and the ranking member for agreeing to hold this critical oversight and investigation hearing and allowing me the privilege to once again address the Veterans Affairs Committee. Thank you very much.
Thank you, Congressman Doyle. With that, I invite the first panel to the witness table. On this panel, we will hear from Dr. Robert Jesse, Principal Deputy Undersecretary for Health at the Department of Veterans Affairs. Dr. Jesse is accompanied by Mr. Mike Moreland, Network Director for VISN 4, and Dr. Gary Rosell, Chief of Medical Service and Program Director for Infectious Diseases at the Department of Veterans Affairs. We will also hear from Dr. Laura Hicks, medical epidemiologist at the National Center for Immunization and Respiratory Diseases with the Center for Disease Control and Prevention. Both of your complete written statements will be made part of the hearing record. Dr. Jesse, you are now recognized for 5 minutes.
And members of the subcommittee, and I would add members from representing constituents in the Pittsburgh area. Thank you for the opportunity to speak to you today about the causes of Legionnaire's disease identified at the Department of Veterans Affairs Pittsburgh Healthcare System. I'm accompanied, as mentioned, by Mr. Michael Moreland, who is the director of the VISN Integrated Service Network 4, Dr. Gary Rosell, the national director for VA's Infectious Disease Program. VA takes the prevention of Legionella seriously and has partnered nationally and locally to understand and control Legionella-related illnesses. The current situation in Pittsburgh is complex and not fully understood, but regardless, we express our deepest regrets to the affected patients, and we pledge that we will do whatever is necessary to implement corrective actions that might prevent this from happening again. Legionnaire's disease is a form of pneumonia caused by the bacteria Legionella, commonly found in water sources. It's typically associated with the water supply of buildings since warm water is its most conductive to bacterial growth. Individuals become ill after inhalation of water droplets containing Legionella, usually within 2 to 14 days after exposure. It's important to note that Legionella is not contagious. The bacteria is not transmitted from person to person. Controlling Legionella in water distribution systems requires active surveillance of both the environment and of clinical infections, and it's a balancing the risk of bacterial growth with the potential for scalding by hot water. To mitigate the latter, VA Pittsburgh has a copper-silver-iron system to further suppress Legionella growth to maintain a lower hot water temperature and prevent scalding. Pittsburgh routinely tests water for the presence of Legionella, and over spring and summer of 2012 performed remediation protocols to the water systems because of positive findings. Despite this remediation from August 2012 through September, they identified patients with pneumonia who tested positive for Legionella who might have become infected while receiving care. Pittsburgh retested its water system again, and the presence of Legionella was again confirmed, and the system was again remediated. Additionally, Pittsburgh worked through the local and state public health authorities to engage the Centers for Disease Control and Prevention, CDC, and request gene typing to compare the Legionella from these patients with the environmental samples. The testing results showed a relationship became available October 31st, and Pittsburgh requested assistance from the CDC. A team comprised of staff from Pennsylvania Department of Health, the Allegheny Health Department, and CDC arrived at Pittsburgh on November 7th, 2012. Based on their findings, CDC recommended immediate remediation of the potable water system, and Pittsburgh promptly implemented an aggressive multi-phase remediation effort, including, again, superheating the water supply to 167 to 170 degrees, followed by hyperchlorination of the hot water distribution system. For safety reasons, Pittsburgh restricted patients' exposure to potable water until testing results indicated that Legionella mitigation was completed. These restrictions were lifted at University Drive campus on November 30th and on the Kynes campus on December 7th. Pittsburgh will continue to test the water at various locations in the distribution system every 2 weeks per CDC recommendations. Pittsburgh also took its existing copper-silver ionization system offline, and to ensure that patient care remained uninterrupted, temporarily installed a continuous chlorine drip to maintain control of Legionella levels until a long-term definitive plan is implemented. VA recognized the need for transparency, and an incident command and call center was activated to communicate news and updates to veterans, staff, and family members. Additionally, Pittsburgh attempted to contact all known veterans diagnosed with Legionella but whose sources of infection was unknown to offer those individuals testing of their home water systems. In response to Legionella cases at Pittsburgh, VA has implemented a number of system-wide control strategies, including the re-emphasizing with all networks and medical center directors the requirements regarding Legionella prevention. The Undersecretary for Health has directed site visits by VA's medical inspector, starting with those having transplant programs being the centers at highest risk. Currently, VA is updating its directives regarding Legionella, which will incorporate the lessons learned from the activities going on in Pittsburgh now, new scientific evidence, recommendations from the CDC, and current industry standards. This is a very complex issue, and we greatly appreciate the support of the CDC, Allegheny County, the state of Pennsylvania, the Joint Commission, and others who have visited with us. The assistance helped us validate that we have taken the necessary steps to effectively reduce Legionella to ensure safety and protection of our patients at all facilities. We are committed to the prevention of Legionella infection and will continue to update our practices, as well as seek expert consultation and analysis to provide the best care for veterans. I thank the committee for the opportunity to appear before you today to discuss this important issue, and my colleagues and I are ready to address your questions. Thank you.
Dr. Hicks, you are now recognized for 5 minutes.
Good morning, Mr. Chairman. Good morning, Mr. Chairman and other distinguished members of the committee. My name is Laurie Hicks, and I'm a medical officer at the Centers for Disease Control and Prevention within the Department of Health and Human Services. Thank you for this opportunity to speak to you today about CDC's investigation into the Legionnaire's disease outbreak at the VA Pittsburgh Healthcare System, or VA-PHS. I want to extend my deepest sympathies to the patients and their families affected by this outbreak. I will provide background on Legionnaire's disease, CDC's role in responding to outbreaks, details regarding the findings of the investigation, and our recommendations. Legionella bacteria are often implicated in outbreaks associated with building water systems. Exposure to Legionella occurs when a person inhales water droplets containing the bacteria. Most people who are exposed do not get sick. Persons with underlying lung disease, a history of smoking, and immune suppression are at higher risk. Legionella causes a severe form of pneumonia called Legionnaire's disease. While treatable with antibiotics, 5 to 15% of patients die. The CDC's Legionnaire's disease program supports public health partners and hospitals by providing assistance through consultations and field investigations, or EPI-AIDS. And these are conducted with the goal of controlling and preventing outbreaks. On October 12th, CDC received 2 isolates from the Pennsylvania Bureau of Laboratories obtained from VA-PHS patients who had Legionnaire's disease, and 1 environmental isolate from the hospital. On October 29th, CDC reported preliminary results indicating a link between the 2 patients and the hospital. The Pennsylvania Department of Health requested an EPI-aid. With the agreement of VA-PHS on November 6th, CDC sent a team to Pittsburgh. The field investigation began on November 7th, and the last member of our field team left on November 16th. The objectives of our investigation were to identify and characterize cases of Legionnaire's disease, complete an environmental investigation, and recommend interventions to prevent ongoing disease transmission. We conducted case finding by searching medical and public health records for cases of Legionnaire's disease at VA-PHS in 2011 and 12. We identified 5 definitely and 16 probably healthcare-associated cases for a total of 21 cases. 5 patients died. The 16 probable cases were among patients who were only in the hospital for part of their exposure period, which means they could have been exposed somewhere else. Our environmental investigation revealed that 29 of 44 samples collected from the hospital water system grew Legionella. The outbreak strain was widespread. VA-PHS used copper-silver ionization to disinfect its water system. We measured copper and silver ions in 11 samples and found that mean copper and silver levels were within the manufacturer's recommended ranges. All 11 samples showed growth of Legionella, and 9 were positive for the outbreak strain, indicating that the copper-silver ionization system was not controlling Legionella growth at the time of our investigation. In summary, the CDC investigation identified an outbreak of healthcare-associated Legionnaire's disease during 2011 and 12. The outbreak occurred in the setting of a Legionella risk reduction program consistent with the National Veterans Health Administration and local health department guidelines. Factors contributing to this outbreak included: 1, persistence of a dangerous strain of Legionella in the water despite copper-silver ionization; 2, reliance upon the VHA directive action threshold. Cases occurred despite Legionella levels in the water system that were below the action threshold. CDC guidelines recommend eradication of Legionella from the water as there is no known safe level. 3, construction on hospital campus likely reduced incoming chlorine in the water, thus promoting Legionella growth. And 4, the hospital believed that their Legionnaire's disease cases were not healthcare associated. CDC made recommendations to VA-PHS to stop disease transmission, including superheating and hyperchlorinating the building water system. They also recommended limiting patient exposure to the water and enhancing their Legionella risk reduction program. The hospital was very cooperative and immediately implemented our recommendations to protect patients. The steps taken by the hospital were successful, and no further cases of healthcare-associated Legionnaire's disease have been detected. CDC will continue to provide support to VA-PHS on an as-needed basis. Thank you, and I'm happy to answer your questions.
Mr. Moreland, were you aware that Legionella was identified in the facility over the Labor Day weekend in September 2012?
Yes, sir. When I look at the data for the water sample testing over multiple years, it is not uncommon to find Legionella in the water. What is required then is an immediate response to that occurrence of the Legionella in the water, which includes heat and flushing, and also going to the areas where you find it and chlorine washing and cleaning it. And over the years, we've had samples that have positive. We've taken that action.
Mr. Moreland, did you know that your employees were caught falsifying copper level data in December 2011?
I'm not aware of anyone falsifying data about the copper silver levels.
Mr. Moreland, between June 2011 and September 2011, VA Pittsburgh had at least 2 Legionella incidents. Did VA issue any written alerts to physicians, staff, or patients so that they could protect themselves and the patients?
Over the course of many years, we've had situations where we had Legionella identified in the water and took remediation action. We've had anywhere between 2 and 8 diagnosed Legionella cases pretty much every year, going back as far as I can find the data, back to 2000.
Please answer the question.
And
would you like me to repeat the question?
yes, please.
Yes, okay. Between June 2011 and September 2011, VA Pittsburgh had at least 2 Legionella incidents. Did VA issue any written alerts to physicians, staff, or patients so that they could protect themselves and the patients?
There was no written alert at that time.
Dr. Hicks, the Pittsburgh VA Microbiology Laboratory is CDC certified for Legionella environmental testing, yet it failed to detect Legionella during routine testing and used out-of-date methods. How is it possible that a lab with a CDC elite certification could fail so miserably and yet retain CDC certification? If this can happen, what is the value of the elite certification?
Thank you, Mr. Chairman. Actually, during our investigation, when we reviewed reports of the laboratory testing that had been done in the environment, we actually found that the lab was quite capable of detecting Legionella in the environment. And they repeatedly detected Legionella in the environment. So I'm not sure why there's a perception that Legionella weren't being detected. They were. They routinely tested their water for Legionella, and they routinely found Legionella. It is my impression that their volumes they were collecting were somewhat smaller than what CDC recommends. So CDC recommends collecting a liter volume sample as opposed to a 100 milliliter sample, which is what the VA was using at the time. What we did when we arrived on site is we actually compared our results. We sampled in tandem. We had the infection prevention folks sample along with us, and they used a liter water sample. And we used a liter water sample, and their lab was quite capable of detecting Legionella throughout the system. So they've always been able to detect Legionella, and I'm a little bit perplexed as to why there's a perception that they weren't detecting Legionella. They were finding Legionella. It was just below the action threshold that they usually use for taking action.
But is it correct that no amount of Legionella is positive?
So CDC recommends that when you find Legionella in a water system, that you do everything possible to eradicate it, because we know of no known safe level of Legionella.
Sure.
However, in the VHA directive and several published reports recommend using a 30% threshold. That means a threshold of 30% of sites positive in order to initiate action. And so I think what happened here is that folks on the ground felt like they had a false sense of security, because the testing that they were receiving test results back, they knew they had Legionella, but their levels of Legionella were typically below 30%, and below that action threshold recommended to take widespread action to remove Legionella from the system. I think it's really important to note that we compared an old strain from 1982, actually a couple of old strains from 1982, to strains from this outbreak in 2012, and what we found is that old strain was almost the same strain from 1982 all the way to 2012. So it indicates that in this system there's been a persistent outbreak strain. It's never been eradicated.
Ranking Member Kirkpatrick.
Thank you, Mr. Chairman. Thank you for your testimony today. Many of you know that I have a background as a hospital attorney, and so this is very serious concern of mine. And Dr. Jesse, I want to start with you. In your written testimony, you say there's been a 217% increase in Legionella from 2000 to 2009. To what do you attribute that?
That actually is data from the CDC. It's national data about the incidence of Legionella in this country. Now, it's important to note that over that time period, the sensitivity, the capability to test for Legionella has improved, and frankly, the sensitivity, the awareness of the need for testing, I think, has become more common.
So you just attribute that not to more cases, but increased surveillance?
Well, it may be more cases, but Legionella historically, is at least the perception is that it's underreported, because if you don't test for it, you don't see it. It's particularly difficult to grow, as was mentioned. There's a certification for labs that actually do culture it. There is a urine test that one can look for urinary antigen for Legionella, but in many instances, patients show up with respiratory symptoms. They're simply put on antibiotics, and it's not necessarily followed through. And it's been a practice at Pittsburgh to pretty aggressively test patients for Legionella, because we know that it's a problem there.
Dr. Jesse, again, would you explain the hierarchy of the personnel who are responsible at the facility level for maintaining the system to keep the growth of Legionella under control? So can you just explain from the bottom up how that is reported and who's responsible?
If it's okay with you, I would defer that to Mr. Moreland.
That's fine. Okay. Mr. Moreland.
Yes, ma'am. The system of control for Legionella, as the CDC said at Pittsburgh, very comprehensive. And so you have the engineering department who's looking at the water and managing the water. Then you have a group of infectious disease professionals who are reviewing the copper silver ionization levels. They're reviewing the water samples, and they're looking at that. So that's the surveillance of the environment. And then you also have the infectious disease docs looking at the incidents of Legionella diagnosed pneumonia. So it starts with, there's an engineering group and the infectious disease group. They meet as a committee and a group. So the next level is a committee of infectious disease. And on that committee, you have clinical professionals and the engineering group, and they talk about this at every meeting, every other month, all through the year. They feed that information to the clinical administrative group, which is chaired by our chief medical officer at the hospital, and they review that data at the executive clinical leadership board, and ultimately that is passed to the hospital director, who oversees the entire operation. And then finally, it comes to me as the VISN director, who's overseeing the system across the 10 VA hospitals in VISN 10 and VISN 4.
How often do you get those reports?
I generally don't see the reports unless there's an issue. And so when the medical center director identifies that there's a concern, then they inform me. And I get those kind of reports when there's an issue of concern.
When did you first receive the report on this facility?
Yeah. The first time that I heard about a concern at VA Pittsburgh was in the fall of 2011. And in that fall of 2011, there were several diagnosed cases, not confirmed as hospital-acquired, but several diagnosed cases. And at that time, the VA Pittsburgh sit down and did a very structured situational review. What was going on, what happened. They made some changes to the system. And rather than rely on the 30% rule, for example, they decided if we find Legionella anywhere, we'll do a heat and flush. So they made some changes to that. They made some changes to the preventative maintenance of the copper-silver ionization system, stepping up and above and beyond what the manufacturer guidelines were. They called in the manufacturers to say, let's talk about this and how does this work, and make sure that they knew what was happening. And they made some changes to that. And the clinical group on the infectious disease stepped up their work. For 5 months after that, we had no cases. The assumption was what the actions that we took care of the issue. And so it wasn't then until months later that we again saw some cases. And this time when it happened, the infectious disease professionals came to the chief of staff, that next level, came to the hospital director, came to me and said, we see this happening again, we're surprised, we think we need some help. And that's when we initiated our actions to go to CDC and say, come help us, we want to make sure we're on top of this.
Would it have been possible at any time just to change your water system, for instance, to bring in bottled water or something, just to make sure that it wasn't spreading to the patients?
And this is where, when you look at data in a 12-month window, you only see 12 months. This is pretty typical what happens over going back to at least 2003 when I've looked at the data. And so it's not unusual to have water in the, have Legionella in the water, and then you remediate and you move forward and you don't see cases. That's kind of what happened. We did have a hospital-acquired case in 2005. We did have a hospital-acquired case in 2007. The difference in this episode is that we had 3 cases in the fall. And that's why I think the hospital director called me, and I said, absolutely, call the CDC. Because it was something different and unusual, and so a different response was required, and that's why we called the help chain.
I appreciate your answer, but I don't think you completely answered my question, which is why not use an alternate water source, why not bring in bottled water or something else during that investigation stage?
Yeah, when you look back, that might have been something to consider, but at the time, the professionals that we were dealing with, the infectious disease docs, we didn't think that it was at a level of danger to be worried. Remember, it's not the drinking of the water, it's the inhalation of the fumes, of the droplets. And so you can drink the water and it's not an issue. The problem is when you breathe it and inhale the droplets. So that's why that. But the reason we used bottled water was actually because we were hyperchlorinating the water. It was not about the Legionella, it was about the hyperchlorination.
What efforts were made to notify the providers that this was an issue?
Well, when we finally confirmed that there was hospital-acquired cases, not only did we inform the providers, but we went on the internet and put it on the hospital's webpage. We issued a fact sheet. The hospital director called each of the union presidents to talk to them to make sure they knew what was going on. We sent out an all-employee news blast. You know, it happened once we had confirmed and knew that we had a real problem, and that was in November the 14th, I think, when CDC gave us their final report that confirmed that there was really a problem.
Thank you. I may have additional questions, but I will submit those, in writing. Thank you. Thank you, Mr. Chairman.
Dr. Rowe?
Thank you, Mr. Chairman. First, I want to to complain a little bit about getting written testimony on a Monday night. I've seen this happen over and over again, and it's very frustrating for me. I actually read these things, and I can't read them if I don't get them. So I almost didn't come to this hearing because there's no point in me being here and wasting my time if I haven't had a chance to prepare. So that's just a bit of frustration. Number two, Saturday I went to a basketball game in Johnson City, Tennessee, where we have a VA. And I presented basketballs to 4 or 5 wounded warriors there at halftime. And a soldier expects to be at risk when they're on the battlefield. They don't expect to be at risk when they're at a VA hospital. We expect to be at risk for our lives then, but we're there to help them at the VA. And I see some real shortcomings here, and I have several questions I'd like to ask. And Dr. Hicks, you said that the VA was complacent. And I know you've had a persistent, when you said that same strain of Legionella had been there since 1982. They obviously had a system from many years where no cases of Legionella were detected. So I think, just listening to this testimony, I don't know, it sounds like that you may have had a sampling error. I didn't realize you used a 30% of the discs had to be positive. You to consider there to be a problem. And when you only test this much volume versus that much volume, when there's not much bacteria in there to start with, that may have. Do you think that's the reason why, or why did they become complacent? Was it the 10 years or so of no cases, and whatever they were doing, they obviously were doing it correctly?
Yeah, it's my perception that they had a false sense of security. They were under the impression that they had Legionella control in the environment because they had a copper-silver ionization system in place. And when we were on site, we measured those levels. Those levels were adequate. And we looked at the maintenance of the system while we were on site and at the time.
Let me stop you there. And why? And you know, obviously you're the expert here.
Mm-hmm.
Why would is that a bad system? I mean, it worked for 10 years.
Yeah,
no cases, and so now you say the levels are all fine. That gives me a very bad feeling, because then what metric do I use?
I think that's a question that we'd like to look into more. We haven't had many opportunities to really evaluate this system. This was actually our first field investigation into an outbreak where there was a copper-silver system. But we do receive over 200 consultations each year related to Legionella. Many of them are related to troubles controlling Legionella in the environment, and many of those are related to concerns about copper-silver.
Here's where I think the antennas should have been up. And it's when you're in a big system seeing a lot of people, and the incidence of something is so small. I understand that. But an outbreak is defined as 2 or more cases. Mm-hmm. That's all. And over in the same bug, in the same environment. That happened, and that was, the antennas apparently didn't go up. So why do you think that was?
Yeah, it goes back to the perception that they were doing everything they could to control Legionella in the environment, and when they were testing their water, they found levels that were below the 30% threshold that calls for action.
But I don't want to delve on this too long, but have other VAs, have you seen this elsewhere? Because if it is, then you've got a system that doesn't work.
What, in terms of the copper-silver system? I have not personally done a field investigation into copper-silver system ionization, but we've received anecdotal reports from other facilities that have also had trouble with it, yes.
Well, then I think that's a metric that needs to be looked at, and certainly if that's the case. I think one of the things that also, this is not in the testimony because I didn't get it, but I was reading a news report, and Dr. Murphy may have some more information on this, but one of the family members was asked to go home and test their water. Mm-hmm. And I think that family member felt like that they may have caused and I think that was very wrong to do that when you knew you had an outbreak right there in your own shop. I don't understand that, and I mean, that's now putting the blame on me that I did something to my dad to cause his death, and that's not the case at all, it turned out.
Yeah, I mean, I think it's very.
You mentioned that early. And
yeah.
I think we deal with these families an apology. And I know that people were trying. I mean, I understand that. I'm not here. People, I mean, good, smart people were out there trying to do that. Dr. Jesse, why aren't the people who were involved in actually doing that here? Why are you here? I mean, because if I had a problem with in the operating room, I'd want to talk to the surgeon who did the surgery.
Well, sir, I'm here in my role as a principal deputy undersecretary, having oversight over this entire system.
And I appreciate you being here, but my question is, where are the people who actually were involved in doing this? They shouldn't be the ones who are here.
Well, there is a huge team of people that are involved in this. It's the building engineers, as you've heard. It's the infection control folks. It's the hospital staff.
When I go to the operating room, there are huge numbers of people there too, but I know who's responsible. Me. Right. It's not the scrub nurse and anesthesiologist and all those other people. There's somebody's responsible at the top. That's who should be sitting here. I yield back.
Mr. Waltz.
Well, thank you, Mr. Chairman, and first of all, congratulations to you and your chairmanship and to the ranking member. I appreciate the work you do.
Thank you, Sergeant Major.
I'd also like to comment on the very proud work, and I think from institutional knowledge of this committee, several years ago, Dr. Rowe, under his leadership, initiated a very similar hearing on contamination of medical instruments, colonoscopy scopes, for example, which led to not only best practices and changes in that, but it went system-wide throughout the country as a best practice. So I appreciate the spirit that this is being held and trying to figure that part of it out. Dr. Hicks, could you explain to me how the protocols at the VA compare to their civilian counterparts in the region and maybe nationally? I understand this is more of a geographic issue to a certain degree, but could you explain to me, is there a difference there or is there a uniform protocol?
Okay. So the VHA directive, there's a VHA directive that's been in place since 2008, I believe. And we also have a CDC guideline for prevention of healthcare-associated Legionnaire's disease. And there are some differences. One thing I would mention before I get into the differences is that most health systems in this country don't have a prevention plan at all. And so I think it's important to recognize that the VA is ahead of the game because they do have a prevention plan. They do require that hospitals have a written prevention plan. And all their hospitals have to comply with this. This hospital had a plan, but it goes to show you that policies are not necessarily foolproof. And so in this situation, we looked at the VHA directive and we compared the directive to our policies. And there are some areas where we would recommend some changes, and we're going to be looking forward to working with the VHA colleagues to make those changes. The one area that I think is probably most critical is this action threshold level. So throughout the directive, there's mention of an action threshold, and it implies that if your testing reveals that you're below 30%, then you won't have healthcare-associated cases, or you won't be at risk for healthcare-associated cases. And in our experience, that has not been the truth, or not the case. We've actually investigated several outbreaks where we've found fewer than 30% of sites colonized. And in fact, this situation it perfectly illustrates why that policy doesn't work, because the VA repeatedly detected fewer than 30% of sites colonized over and over again. So they thought that they had their Legionella problem under control. So that was a big issue that I think we really need to work on together. The other issue has to do with the volume of sampling, and CDC typically uses a liter volume when we sample, and that increases our ability to detect Legionella when we're doing an investigation.
Was this an issue here that the sample size was too small?
I think, from what I can tell you, I don't think it made a big difference in the ability to detect Legionella in the long run, I don't think it plays a huge role in this particular outbreak because they were detecting Legionella, even with the smaller volumes.
Then the question I was going to ask on this, I understand, is it's this issue of should we test for everything? You can do an X-ray for every single thing or whatever, but at some point the cost-benefit analysis is reduced. Is there a point where you have these areas, especially in the Northeast or whatever, how much does it cost to test? What's it cost to test?
Yeah, I can't speak to the exact amount. I'd be happy to get back to you on that, but it's expensive. And of course, the larger volume you use, the more money it costs because it takes more money to ship the samples. So
would it be just not wise to test all the time at these places? Would that be an unwise use of resources that wouldn't detect or wouldn't prevent?
Yeah, I mean, I think that in a setting where you've decided to use testing as your measure for the effectiveness of your legionellosis prevention plan, I mean, you do have to routinely test. But I think it's important to note that testing is one parameter to measure, but there are many others that you can evaluate in addition to actually evaluating Legionella in the environment. So things like temperature and your disinfection levels and pH and chlorine. So there are...
This issue of hospital-acquired infections and illnesses is far broader than this issue, right? And all of these come together.
Right.
Okay,
this is very complex.
Well, my time is up. I'd like to end by thanking all of you. And the question was, why are you here, Dr. I'm glad you're here, and I know it's public health. You're a public health expert, and I think this gets into the broader question. Obviously, I think, and I appreciate, Dr. Hicks, your concern. We're in one patient infected that could have been prevented is one too many, and it's very difficult to get to zero, but we have to strive for that. So I appreciate the spirit that you're taking, Matt. I yield back.
Mr. Holzkamp.
Thank you, Mr. Chairman. I appreciate the opportunity to ask a few questions this morning. First, I had a follow-up with Dr. Hicks. You mentioned 30 years of Legionella in this facility.
Yes.
Are there other cases CDC is aware of where you have 30 years of the same strain of Legionella?
Well, we only conducted the investigation going back to 2011, so I can't comment on cases prior to 2011, but I believe earlier in the testimony some folks mentioned that there had been other cases. So perhaps my VA colleagues can comment on that.
And I'll follow up with that.
Yeah.
I'm just curious what you knew elsewhere given your regimen. Do you have a different standard certification regimen if you have 30 years of persistent cases of the same strain, or do you just treat them all the same across the board?
I mean, our approach to legionellosis prevention is if you find Legionella in the environment, especially in a place where there are vulnerable patients, you must try to get rid of it. The policies that had been in place for very many years allowed for about 30% of sites to remain colonized. And these policies were carried forward over many decades. And so what I think is really important here is to understand that there was a perception that if you have low levels of Legionella in your system, that you won't see cases of Legionnaire's disease. And that's just not true. When we tested...
Yeah, well, it's certainly not true in this case. After
Right.
30 years on and on,
Right.
and that would be a question, if I could, for Mr. Moreland. How long have you been in your particular position? And so this whole time you knew there had been, at that time, 24 straight years of this persistent strain of Legionella in this particular facility.
When they're talking about that particular strain, they're talking about the genotyping for that specific strain. And so not every case is necessarily from that specific genotype strain. But the strain that they found now, I think, matches 6 out of 8 of the chromosomes, I guess it is, for that strain. So it's kind of a granddaddy of a granddaddy to that strain. So it's a very closely related strain, but that doesn't mean that there were not different strains of pathogenic Legionella that occurred on occasion across the years.
And my question is, are you doing the same testing regimen in other facilities? that do not have this 30-year case history? Did you treat this facility any differently? It's my understanding elsewhere in VA, there is a facility, and I'm not sure which one it is, actually does testing 3 times a week. How often did you do testing in this particular facility?
The hospital, the testing at the VA Pittsburgh historically has been every other month. And that's been not just one test every other month, but multiple tests of multiple distal sites in the water system during those months. Now, since we've had this outbreak, we're doing it every 2 weeks. And we will continue that until we've got a system where we believe it's stable. There's a lot of activity, if you would like to ask about, what are we going to do the way forward and how we're going to change? Because, we've looked at what we've done and the effectiveness of that, and we've decided to move in a different direction and use a different system for control.
Yeah, I appreciate that, Mr. Moreland. My concern, though, we've got the testing. One can argue that probably not enough testing, improper sample size. Also, the question I have is remediation.
Right.
And could you describe very briefly the remediation efforts since you arrived there in 2006, how often they were done, and clearly they were insufficient. What would you have done differently, and did it meet the CDC standards for necessary remediation?
Yeah, the testing was done, and when we found positive samples, we did remediation. The remediation included...
Only if it was over 30%?
Not necessarily. While that is the VA policy to look at what level do you think, and it's not directed that you use the 30%, but that's kind of what we had in our policy. However, we still did the remediation at lower levels. And as I mentioned earlier, in 2011, they decided, let's do remediation no matter what the level. And so for at least a year, we've been doing remediation every time we found some Legionella. The remediation...
And you found Legionella in every time you tested?
Not every time we tested.
No, that's not what you said earlier. Every test you found some level of Legionella.
No.
Is that incorrect, the earlier statement?
Not every test was positive. We did multiple tests. So we may have done 15 or 20 tests, and maybe 3 or 4 of them showed positive. Or
positive at the 30% level, when you say a positive test?
Those positive tests, there would be 10 sites. You go out and you test all 10. And if there are 1 or 2, that's less than 30%. However, we would remediate those 2 sites anyway.
Even though it's in the same system, you mean?
Even though it's in the same system, yeah. Because it's interesting, the Legionella can be in a dead leg of a pipe. It can be in the faucet. It doesn't have to be in the entire system.
Yeah, and I don't know where it is. All I know is we have deceased veterans and their families asking for questions, answers here. And my question is, you're now saying you've remediated every single time you've found a sample with Legionella in it.
If I may give a concrete example, following...
No, I want a quick concrete answer. If you can provide back to the committee, every time you did a remediation, right. And has there been independent review of all the sampling? Who did the sampling for you?
The sampling of the Legionella water samples?
Oh, yeah, that's what we're talking about.
Yeah.
Well, I don't know what else we'd be talking about, but go ahead.
Silver test as well. But for the Legionella test of the water, it was done by our lab in VA Pittsburgh, which is a certified lab, and that lab continues to do testing for multiple hospitals across the VA.
And they recommend the 30% level?
That recommendation of the 30% level is in the policy by the infectious disease group that is in our local VA policy. But despite that policy set, and it's also at the national policy level, despite that number, in 2011, when they wanted to make sure that they were doing above and beyond, they started doing heat and flushes and copper washing, chlorine washing of the faucets every time at the site where they found positive tests.
Okay, I appreciate that, and I yield back my time. I look forward to a list of the remediation efforts tied to the testing results. Thank you.
Thank you, Dr. Holzkamp. Ms. Custer?
Yes, thank you very much, Chairman and Ranking Minority. Thank you. I have a question to follow up on this 30% because it seems as though that's where our attention is getting focused. And I wanted to ask Dr. Jesse whether the VA has a plan to reevaluate the existing guidelines and policies that might not have been adequate when it comes to preventing Legionella or the outbreak of Legionnaires? And would you consider a change in recommendations to lower that to a zero threshold or some number less than the 30% to address what Dr. Hicks has described as a false sense of security?
Yeah, so the Legionella directive, the National Legionella directive, is under revision now. They're completing their evidence review, which will review all the published literature, particularly that's been out since the last directive was put in place. And as I said earlier, that directive will be informed by the lessons learned from Pittsburgh, as well as the emerging scientific evidence, consultation with CDC and others. So I can assure you that there will be a change in that 30% threshold. That directive was written in 2008, and it was informed by prior experience. And the experience across many years was that that appeared to be a safe level. As Mr. Moreland said, in 2011, they changed, despite the national policy, it doesn't restrict you, but they said because of the issues here, we're going to remediate, and at one point, even finding one of 27 samples positive, they did a remediation process.
Yeah, it just seems as though this is a much more persistent bug than had been earlier predicted. And Dr. Hicks, do you think that would be an appropriate change in policy that could hopefully, I mean, the purpose of this hearing is to protect future veterans and to spare their families that, and I want to agree with my colleague on the other side of the aisle that we understand our troops are going to be in harm's way, but when we get them home safely, our goal is obviously to keep them safe going forward.
So I absolutely agree. The VHA directive is wonderful because there is a policy in place intended to prevent legionellosis, and this is a policy that has had great uptake from what I understand across the VA. But I do think this is an opportunity to identify where we can make improvements so that we can protect this very vulnerable population.
And I just have one other question, and that's with regard to the people that are working in this facility. Have you had any instances of employees that have been stricken with Legionella or Legionella leading to Legionnaire's disease? And also, what are the precautions that are being taken going forward? Because I could imagine this would be a stressful work environment.
Notice on November the 14th or 15th to tell everybody that we had a concern. We advised every employee, if you have any kind of respiratory concern, please come to Employee Health. We will provide test and assistance with you. We've had people come with respiratory concerns, but we've had no diagnosed Legionella of employees. The challenge is you have to get a clinical test to make sure it's diagnosed, and so there are concerns of a couple employees that had pneumonia, but they don't have a diagnosed Legionella diagnosis, and that's a concern. My understanding is that they filed a claim with the Department of Labor for workman's comp, and we certainly support their opportunity to file that claim and doing that. In terms of the way forward in the water system, was that what you asked me?
Well, I'm just thinking about precautions both for incoming patients, but also particularly the people who are working there day in and day out, that they are exposure to an obviously very dangerous bug.
Yes, ma'am. I think the most important thing is to clear the system of the Legionella. And what we're in the process of doing now, in fact, just a week ago, because since this started in November, we've been sitting down with experts. What do you do? How do you make things better? What can we do in a way forward? And one of the main suggestions we've had is to raise the temperature in the pipes. And so and as we talked earlier, one of the challenges is when you raise the temperature, you've got to be careful of scalding patients. Because I don't want to be back here talking about scalding patients. And so what we've done is we've purchased some scald protection faucets and shower heads that we've just let a contract on. They will start the installation of those. Once those get into place, we can raise the temperature in the pipes to a much higher level, and we believe that will add a higher level of suppression of Legionella, and then we'll move forward with some consideration of other supplemental systems.
Thank you.
Thank you.
Thank you, Ms. Custer. Chairman Miller?
Thank you very much. I want to thank Dr. Murphy and Mr. Dole for bringing this personally to my attention. But Mr. Moreland, I got a couple quick questions. It's just your testimony. You say that this all started in November?
I said in November of 11 that we had some concern and took remediation and then had 5 or 6 months of no concern. And then it returned again in the fall of this year, and that's when we are in this current outbreak.
And you allowed employees immediately, once you found out that it was an issue again, that's when you told the employees to go ahead and report to you if they had any respiratory concerns?
Once we confirmed that there was a substantial outbreak in the water, yes, sir.
How long did that take for you to confirm there was a substantial outbreak in the water?
When we got the final report from the CDC November the 14th of this year.
When did you know any earlier than that, before the final report?
Over the course of, and this is, I'm sorry you missed, but over the course of years, we've had Legionella positive water tests.
Oh no, I've been here.
Oh,
I've been monitoring. I apologize. I've been monitoring on the television as well.
Okay.
Yeah, I'm very well aware it's been in the system for a very, very long time.
Right, and then we've done remediation and cleared it, and then done samples, and we've done that for years. So it wasn't really until we got the confirmed report from the CDC in November that we recognized that we had a very significant issue and took aggressive action for remediation.
Did you suspect before you got the final report from CDC that you had a serious problem?
I think that what happened was in early September and into October, we had concern, but no confirmation.
What did you do when you've had that concern? What action did you take?
Yeah. We collected samples from the patient's clinical samples. We collected water samples, talked to Allegheny Health Department, got the information to them so we could get it to CDC, asked them to help us look at the situation.
And once that occurred,
we did heat and flush of the water.
Once that occurred, who did you notify within the physician groups or the staff? I mean, did anybody know that this was happening?
The infectious disease group knew because they were the ones that were working with the local clinical people at the hospital.
But the staff did not at the hospital?
We did not do a general announcement to the staff, no, sir.
And because you just didn't think that it was warranted until you had the final report from CDC, or?
We had had these kind of concerns multiple times over years and done heat and flushes and had things resolved effectively. This time we were concerned and called CDC, and once we confirmed it.
But wouldn't you want a physician to know? I mean, wouldn't physicians want to know that you had a concern that was so serious that you were bringing in the Allegheny County Health Department?
Well, certainly the chief of staff, the medical director of the hospital, the infectious disease community, we were working in an open environment talking about how to work.
Open environment, but again, open environment to who? I guess my concern is, right, if I had a suspicion that there was if I had had this for 20 years and that I thought that there was a very large suspicion that it was more than what I've been coping with, I would have thought that I would have, but where did the 30% number come from? I mean, I know you were saying the clinical group, but I mean, is that a written policy? I'm interested to know where the 30% comes from.
Okay, I've heard a lot about 30% so far this morning, and I think the 30%. First, let's talk about the directive, because that's where the hospitals get their information from the VA. And what it says specifically is the directive specifies that each facility set its own threshold, and that's Directive 2008-010, page A5. The directive then goes on to recommend 30%, and that's because in the literature, 30% is noted as a risk level. It is consistent with Allegheny County and many other places. So
is Legionnaires, I mean, is the problem any less virulent in Florida than in, why would you give hospitals the ability to set their own levels?
Oh, and this was discussed at great length when this directive was written by the consensus group, because there is no absolute data on while the CDC, I agree with, it is impossible to know what a safe level is. Legionella is ubiquitous and it's very, very, very hard to eradicate. So the literature is inconsistent now, even now, about what those numbers mean, which is why we gave enough flexibility to the facility to set their own threshold, because they know their pipes, they know their system. And in fact, Pittsburgh did just that. When they considered that they had some issues, they remediated with no regard to the 30% and did heat and flushes and all the things that we've been talking about. So the flexibility is designed for the stations, because there's a lot of hospitals with a lot of plumbing, and yet the 30% is in the literature. So I think that everything that they did was consistent with the directive. Now, should there be more rigor?
To answer your question directly, yes, there is a difference between Pittsburgh, Florida, Arizona,
Yes.
California, both in terms of the prevalence of the disease. The CDC will say that it's the Mid-Atlantic, Pennsylvania, New York, and New Jersey where it's the highest, and other areas of the country it's significantly lower. And the other issue is that I think the number is 25, but many of our facilities get their water from municipalities who treat their water with monochloramine, which seems to be a way to get it to the tap without having to do anything intervening. So it would not make sense to have a national policy that has a one-size-fits-all. The important thing is that every facility needs to assess its risk of Legionella. It does that through surveillance of both the water supply and clinical cases, and based on that, builds its strategy.
Thank you, and thank you, Dr. Murphy, for allowing me to speak out of order.
Dr. Murphy?
Thank you, Mr. Chairman, and thank you for holding this hearing. So how often is a VA Pittsburgh required to test its water systems?
So the requirement is based on...
Just how often?
It would be absolutely required twice a year.
Twice a year.
And that would be...
Every VA the same?
No.
Okay, so it's Pittsburgh is twice a year. Other VAs may be how often?
Other VAs may be not at all.
Okay, so this is based on
that. But it's...
How about the CDC? How often does the CDC recommend hospitals test their systems?
So in this setting where there are transplant patients, we recommend that a testing protocol, but there's no...
Once or twice a year, you don't have a protocol. Now, for those who are not aware, the VA system in Pittsburgh is in the midst of the University of Pittsburgh campus, across the street from a huge Peterson Event Center, where we have basketball games, a block away, or across the street from Western Psychiatric Institute Clinic, a block away from Presbyterian Hospital. A lot of transplants are done there, Montefiore Hospital, several hospitals nearby. When CDC was looking at Legionella levels, did you check any other hospitals nearby?
No, we didn't check any other hospitals nearby.
Do we know if they have Legionella levels that are a problem?
I know that other hospitals in the area have struggled with legionellosis, and it's a very common problem in hospitals across the country.
I understand that, but I'm saying here we have one hospital here, and we have several other hospitals across the street, and nobody checked for their Legionella levels. Am I correct?
Yes. Well, I don't know what their current policies are.
That's important too.
Yeah.
I'm just trying to find out if CDC checked, and I would hope we would find it out, because if you're going to do an epidemiological study, you have to find out why at one building and not others. When did Pittsburgh VA first learn they had some problem levels with the outside the normal reading levels with their copper silver ionization system? Do you know that, Mr. Moreland?
For as many years as I know, there's always been issues of maintaining the copper silver level, and that's why they have a valve that you adjust the levels. And so if you look at the levels over several years, there's low levels and high levels, and then a group of levels in the middle.
And to your knowledge, no one has ever caught any staff putting false numbers down for copper silver ionization levels?
I have seen no such evidence.
Whenever there is abnormal or outside the normal limits copper silver ionization levels, does this increase the risk that Legionella could be surviving in the water systems?
I really don't know that. I mean,
Well, perhaps we'll have some testimony later on that. If you don't know, we'll just have someone else ask that. And it was first detected in the system when? What was the date of that? When you first detected Legionella in the water system?
Legionella has been in
1980s.
But I mean,
Since 1980s.
during this recent outbreak? Because you had several years without Legionella cases.
We had, looking at the data from 2003 till 2012, there were 2 to 7 diagnosed cases every year of Legionella, but not hospital-acquired. We had a hospital-acquired case in 2005 and a hospital-acquired case in 2007.
Well, I'm going to this thing, and listen, Mr. Moore, you know I have the highest respect for you in the VA, and you've received national awards from the Veterans Administration for your work to stop hospital-acquired infections. Something broke down here. And one of my concerns also is, here you have some cases showing up, and the medical staff wasn't notified. This is a serious problem that if it's exceeding, if you have Legionella above the 30% threshold, am I correct on that? So showing above, medical staff was not notified that it was showing above that level. But even then, we're not sure if this you could have 1% and it could still be dangerous.
That's the point I was making, and actually most of the cases that occurred here were when levels were well below 30%.
It almost sounds like in some ways it's people washing their hands and saying, you know what, I didn't set the standards. There are no national standards. Everybody gets to make up their own standards. 30% is some number that people pulled out, but 1% could be enough. And we have some people dead here, and I don't hear anybody saying, you know what, this is wrong. The CDC and the VA and hospital associations nationwide are going to set some other standards here. Mm-hmm. Is that going to happen?
One thing I'd like to mention is that there's a new standard about to be released, and CDC has been working on that standard with a number of other experts related to Legionella. And this standard is called Prevention of Legionellosis.
Can I just ask something?
Yeah.
Can I just give you another minute here, because a couple more critical things I just want to ask. Would that be all right, Mr. Chairman?
Go ahead, Mr. Murray.
When you tested the water systems at the Pittsburgh VA, how many different water systems are there within the Pittsburgh VA system?
It's a very complex water system.
Just how many?
Oh, I couldn't tell you off the top of my head. I'd have to get back to you on that.
3, 4, 5, 6, maybe? Self-enclosed, that sound about right?
I think it was 4.
4. There's 4 different systems. Did you test all the systems?
Yes.
And when the systems were flushed, were all the systems flushed thoroughly?
Mm-hmm.
Every faucet, every shower head,
Right.
everyone was tested?
Yes. Well, not every single one was tested, but many of them were tested.
What does that mean?
So we sampled, when we went in, we had to collect a representative sample.
But I also heard someone say that, you could have some dead-end pipes and things of which could still be remaining in there.
Correct.
And so a representative sample.
Right.
At least 5 people died. One other thing I want to point out here, when people are saying that there was some testing done, what I have here is some information that says that's not true. Some testing was done on urine antigen levels, but Legionella cultures were not done on several people, and we don't have names, but patients number 1, 2, 4, 6, 7, 11, 12, 13, 19, 21, 22, 23, 25, 26, and 28. There was no Legionella cultures done. Why was that?
So these are individual patients. I can't answer the specifics of whys for each, but I would say as a generalization, it's often difficult to get sputum, and the cultures have to come from sputum from those patients. Often when you get a urinary antigen test, and patients may already have been put on antibiotics, which would suppress the growth.
And if we had
I can't answer.
If we had the information, though, could we also compare the sources of that? If we looked back on some more things from the old lab, the pathogen labs that would have had some of that old data in terms of sources?
So I just want you to know that we were able to compare what we had from the patients to what we found in the environment, and we had isolates from both patients.
But you didn't have the old data from the old lab. I understand that was destroyed.
Some isolates from the old
But the old lab, all that old was, a lot of that was destroyed, though, right?
I don't know, but I know that we had 3 isolates from the 1980s for testing.
Mr. Chairman, I hope that someone can answer this question because it is critical, because I understand a lot of that data had been destroyed. And I hope the committee, I understand my time is up, but I hope you or someone else will follow up and ask that question. Why was all of that data destroyed, and who ordered that? Thank you, Mr. Chairman.
Thank you, Mr. Murphy. Dr. Benishek.
Thank you, Mr. Chairman. For all of you at the VA in Pennsylvania, have you ever been there, Dr. Hicks? Dr. Jesse?
I haven't been there. I have not.
Have you been there since this happened and interviewed people?
No. Dr. Roselle?
Mr. Moreland, have you been to the?
Yes, I have.
So you were there since this happened and interviewed people?
I have been there, and I've talked to numerous people involved in the process. Yes.
Well, that's one of the questions that I'm concerned about whenever we have this sort of hearing, is that we just don't get to talk to the people that are directly involved. And that's very frustrating to me, because it seems to be filtered through people like you. And I don't understand why we can't get to talk to the people that are actually involved to try to get a better answer. It always comes through, congressional liaison people. So is there a better answer? Can anyone tell me why that some of the people from the Pittsburgh VA aren't here specifically? Dr. Jesse?
Well, it was our feeling that this is a broad issue, that Mr. Moreland could, represent the events that occurred at the VA. Dr. Roselle had a team that went in and did a thorough investigation, spoke to everybody there. Not everybody, but the appropriate.
I know, but I mean, only Mr. Moreland has actually spoken to people at that VA. So
no,
none of you.
Dr. Roselle has. Dr. Roselle took a team in of infectious.
Dr. Roselle, you were there? Oh, I didn't get that.
Yes.
So who exactly did you talk to, Mr. Moreland, at that VA?
I have talked to the hospital director, the chief medical officer, the chief of infectious disease, the chief of engineering, the water maintenance supervisors, and other people as well.
So there's not a really good answer to the question as why we couldn't hear those people ourselves? No, I guess not. Now, let me ask another question about this 30%. This is 30% of the samples that they're taking. That's the threshold where something has to be done. So are these the same places that are being sampled every time? I mean, is it the same place that is positive consistently, and there's only 20% of the places that are positive? I mean, is that what happens? I mean, are you aware if the 20% that's positive are the same sampling sites?
So they do a random sample across the entire system, and if there's a positive, they do a heat and flush and then retest to make sure that it is in negative, and then they rotate around.
So are they aware then which sample site is positive?
Absolutely.
And was it the same sample sites that were repeatedly positive?
I haven't looked at that closely.
That would be sort of like an important thing, wouldn't it? I mean, if the same site is consistently positive, that 20% doesn't really mean anything then, because it's the same site that's positive all the time.
They tested the site, then they heat and flushed, and they retested to make sure it was negative. And then they went around and picked other sites.
Can you explain to me a little bit further about why there's this discrepancy between the CDC and the no tolerance and this 30%? Who made that decision?
When that policy was written, because the science is not very good, I brought together a consensus group of experts, including people from Pittsburgh and others.
Who made that decision? Do you know?
The decision was made when we wrote it. It was a group decision. We wrote the directive. Then it goes through a standard concurrence process.
So that was your decision then? Or was there a panel?
Don't make decisions alone. It was a consensus group in the.
What group is that? What's the name of that group?
It was a group formed just for this purpose.
So do you ever talk to the CDC about this? Because they're obviously their standard is different than yours.
Yes and no. The CDC, yes, we have talked to the CDC multiple times over the years. Remember, the CDC does not even make a firm recommendation that water should be tested at all. For transplant centers, it says periodic testing can be done. For non-transplant centers, it's an unresolved issue. So when we...
Well, I guess I don't understand when she's telling us that there's no percentage of Legionella is acceptable, and then you're saying that up to 30% of the samples can be positive. So I can't understand the difference between that.
The difference between that is there has been and still is differences of opinion on action levels, water culturing at all, and Legionella remediation. The science is imprecise, so we end up making decisions that are reasonable, and again, Allegheny County has made the same decision.
So do you think that this decision is reasonable at this time?
The group is going to reconvene. In fact, it was supposed to convene today. It's been postponed. To start looking at this again, going back to the science.
So you think it's unreasonable? Today you'd say it was unreasonable.
Pardon me?
Today you'd say that was an unreasonable decision that you guys made in retrospect.
We're going to look at all. I try never to go into retrospect.
Thank you, Dr. Benishek. Mr. Rothfuss?
Thank you, Mr. Chairman. My apologies for not being here for the earlier testimony. We have multiple hearings going on. Just a couple quick questions. As I understand it, there was an issue spotted back in November 2011. Is that correct?
Yeah. In 2011, there was one hospital acquired, and then a group of other diagnosed cases of Legionella.
But did testing reveal that there was Legionella in the system at the time in November 2011?
Yes, it did, and there were actually 3 rounds of remediation that occurred at that time.
And
in fact, in the final was where a single sample of 27 was positive, and they did another heat remediation.
And that was over a period of how many months from November 2011?
Well, that was September, October, November were when the cases were identified. There actually was a remediation in August, in November, in December, and in January. From December through April of 2012, there were no cases.
And so between January 2012 then and November 2012, there were not...
No, actually, through April of 2012, there were no cases. There were 3 cases of Legionella diagnosed at the facility. One in March, 2, or one in May, 2 in June, none in July, and then in August, this seemed to come out where 2 were hospital acquired. This is where the epidemiologists, infectious disease folk at the hospital became concerned because they needed to link them back. In fact, one of those patients was never hospitalized; had only been there, I believe, on 2 occasions for outpatient visits. But involving the CDC through local and county health authorities and doing genotyping, which takes time because you have to culture and grow the Legionella and then do the genotyping. So those results came back to the VA on October 31st. November 2nd, I think the letter from the director went out through the county and state authorities to request intercession of the CDC. That team was on site on the 7th, was there through the 16th.
Following the remediation, that's all of the 2011 finding. What would the standard procedure would have been for testing again?
Well, again, the standard is one that is set by the local system. At I think minimum mandate would have been twice a year because they have a transplant center. The practice was they actually did it more like 6 to 10 times per year, and in fact, testing was done in March, in April, and in June.
And the results of those tests?
I shall put my glasses on and tell you. 0 in March, 0 in April, 5 of 26 in June. Remediation followed that.
Okay, thank you. Thank you, Mr. Chairman.
Thank you, Mr. Rothfuss. We're going to begin a second round of questions with the same panel. Dr. Jesse, was the outbreak of Legionnaire's disease in Pittsburgh preventable?
So I'm going to answer that cautiously.
Just answer, please.
It would be preventable by maintaining a water temperature at the tap of 130 degrees. There is a risk, and the risk of scalding of patients, and that's an unacceptable risk.
Versus patient dying.
Patients die from scalds. So what we're dealing with is an area between a water temperature between about 110 and 130 degrees, where one has to balance the risk of scalding patients.
Was it preventable?
Was it preventable? As I said, if you put
Was
the
it
water temperature
preventable?
high enough,
Can you just answer the question?
I've answered the question. If we turn the
You're
water
saying that it is
temperature-
preventable? Okay, please put up a slide. According to information provided to this subcommittee by the VA, as of December 17th, 2012, can we get that up? Okay, bring it up. There were only 2 Legionnaire cases in 2012, and neither were hospital acquired. Okay, wait till that's up. Okay. In speaking to just one of the county health departments that VA would typically report Legionella cases to, VA reported 7 Legionella incidents in 2007, 6 in 2008, 1 in 2009, 5 in 2010, 10 in 2011, and 7 in 2012. These numbers don't necessarily represent hospital-acquired Legionella, but CDC's investigation that covers only 2 years shows 14 Legionella cases, definitely or probably acquired at the VA facility in 2011, and 17 Legionella cases definitely or probably acquired at the VA facility in 2012. There is a glaring disparity between what VA accepts responsibility for and what CDC and others attribute to the VA. Would any of you care to comment on that?
Sure, let me make a couple of comments. I think you started off talking about 2 cases, and let me make very clear what that refers to. When we had seen the issues in Pittsburgh at a national level, we went to every VA facility and said, do you have any cases of Legionella now? A point-in-time survey. There were 5 cases, 2 in Pittsburgh. I think 1 in New England, 1 in the Intermountain West, 1 in the South. That was a point-in-time survey. Is no way intended to talk. It was point prevalence, not incidence. In terms of the number of cases being reported, be very cautious because CDC often reports county data. And so in Allegheny County in 2012, there were 50 plus or minus 1 or 2 because of late December, we're not sure, cases of Legionella. 5 of those were VA patients, but that's only patients who were in the county. It's not from the hospital, it's county residents. So it's a different reporting structure. As my understanding and looking at CDC, we fully agree with the number of cases reported by the CDC. We fully agree with the attribution of hospital acquired.
Mr. Moreland, why was the lab data destroyed in 2006?
The special pathogens lab was closed. There were multiple sets of data and specimens in the lab. All lab specimens that were categorized, labeled, and had a catalog were moved intact to the other laboratory at the VA Pittsburgh. Those things still reside there. The only thing destroyed at the VA Pittsburgh when the special pathogens lab closed were uncategorized, unlabeled samples that did not have a catalog of what the samples were. So they were unknown samples left in the lab. That's the only thing that was destroyed because uncatalogued samples left in a laboratory are considered biohazards and need to be destroyed.
Ranking Member Kirkpatrick.
Thank you, Mr. Chairman, and thank you, panel. I have many questions about this, and I will submit most of them in writing in the interest of time for this committee. But in my briefing materials, I want to take the conversations a little bit different direction. There's a note that there was a sprinkler system interruption due to a water line break in November of 2012. And then I also want to reference for the record the CDC report of January 25th of this year. And here's what it says. Extensive construction at the hospital. The timing of construction work at the hospital coincides with the outbreak. Construction likely introduced organic matter to the potable water system, increasing consumption of chlorine in the municipal water supply, leading to amplification of Legionella. Residual chlorine in the water system, although at adequate levels in the incoming municipal water supply, was at an insufficient concentration for microbicidal activity at all distal sites measured within the hospital. That's extremely concerning to me. Dr. Hicks, could you talk with me about that? And I'd like to know, what the circumstances were, but also what remedial efforts have been put into place.
Okay, so I think it's important to note that this hospital wasn't paying particular attention to the chlorine levels because they had a copper-silver ionization system in place, and the claim is that copper-silver ionization in of itself is effective for disinfecting water. What we found here is that obviously during our investigation, when we measured copper and silver levels, we found Legionella in all of those samples, and despite adequate levels. So we were trying to hypothesize as to why this happened when it did, because this copper-silver system has been in place for so many years. So we looked back at the construction work that had been done, and the construction work actually was in time. It was right before this big increase in cases, and so we hypothesized that the construction introduced material into the water supply that consumed chlorine. And it may have been that quite a bit of chlorine was getting through to the distal parts of the building and lowering levels of Legionella prior to the construction work, and that may have kind of produced this synergistic effect with the copper-silver system. But once that chlorine was out of the picture, once there was no chlorine in the system to knock back Legionella levels, then Legionella just grew rampantly.
Let's see, Dr. Jesse, can you address in terms of a system-wide effort or policy to be more vigilant during times of construction? It looks like there's definitely a clear link.
Well, it may not be so clear. There's been construction on that campus going back many, many years. I think the issue here is that this is indeed complex. What we're trying to answer is, why did a system that was apparently effective for many years all of a sudden start having problems, and despite having adequate levels of copper and silver ions in the system, could still grow Legionella? And so, as Dr. Hicks said, you have to start looking beyond the obvious, and what are other things that might have contributed. And construction being one. So,
excuse me for interrupting, but not to quibble with you, but my reading material says that Legionella has been at this campus since 1981.
Legionella has been everywhere since time immemorial.
Right.
So
my question, I understand system-wide, but my question is have you looked at construction? You say that happens all the time on the campus, to be more vigilant, and maybe Mr. Moreland.
Absolutely, I think we need to be, and as we are rewriting the national directives, I think this is something that has to come into play. It clearly is one of the things that explains the difference, but it's at this point it's a hypothesis, but I think we need to take it seriously.
Thank you, Mr. Chairman. I yield back.
Thank you, Ranking Member Kirkpatrick. Dr. Rowe.
Thank you, Mr. Chairman. And I think we have to go back and say, why is this a serious issue? And the reason it's a serious issue that Dr. Hicks brought up was that Legionella pneumonia carries a 5 to 15, some as high as a 30% mortality rate. That's higher than open heart surgery. So that's why it's a serious issue, because it has such a high mortality rate. Mm-hmm. And that's why we have to be vigilant and try to prevent this, because we know that, and these are either immunocompromised patients or patients over 65 or patients with chronic lung disease or any of the debilitating diseases that we get as we age. So that's why it's important. And the chairman asked a minute ago, was this preventable? And I think you can say that, yeah, the easy answer is a lot of things were tried. The answer is yes, because it is prevented in a lot of other places. And there are, I think, 37 other systems that use a copper-silver system that haven't had this problem. So it's clearly working somewhere. Something happened, and Dr. Jesse, you may be right. It could be the factor, the construction, whatever, that there was another factor in there, if the levels were normal. But some of the analytics that we've got here, and this is a very cumbersome book, I obviously didn't read that all last night, but that suggests that these levels were not adequate. Is that right?
So I don't know, and I can't speak to the necessity to constantly maintain these levels at all times. We do know that these systems require a lot of manipulation to keep them in line. The testimony submitted from Pittsburgh Presbyterian describes a process very much like what VA was doing, measuring, readjusting constantly. But we also know there's been another hospital in Pittsburgh that, despite having good silver ion levels over a long period of time, also was no longer handling the Legionella burden and put in place a monochloramine system. That was reported in an abstract.
It says these analytics right here say that for more than a year that the silver levels were not adequate.
I don't know if they were not adequate. They were probably points in that year when they were not on flame. I don't think that there was time over.
Yeah, these are yours. These are not. I mean, these are reports from the VA here. So we need to get that answered, because we need to know that. But obviously, those patients in that hospital and their families need to know that. I think that's we'll get it written after this is over. We'll put that in writing for you. And Dr. Hicks, have you seen this? I know you don't just look at VAs, you look at hospitals across the country. Have you seen this? I've been in a medical center with 600 beds and a VA hospital right next door to it that's a large VA, and I haven't seen this problem at either one of those facilities in over 30 years. I've been in Johnson City, Tennessee. Have you seen this in other hospitals where outbreaks? And again, when you're seeing thousands of patients, I realize that it's hard to identify two, which would be an outbreak. I got that. I understand that. Have you seen that?
Yeah, I would say that it's a very unfortunate occurrence, but healthcare-associated Legionnaire's disease is quite common. And in the U.S., we believe there are somewhere between 8,000 and 18,000 cases of hospitalized Legionnaire's disease every year, and a good proportion of those are healthcare associated. So this is not an uncommon occurrence in hospitals, and I would say that I suspect, and this will be very disturbing to many of you, I suspect that many of these outbreaks go undetected. I mean, I think this is a situation where this outbreak was detected because they have a very aggressive testing policy, both for testing patients.
I would think, though, that, we're pretty, when you look at an x-ray, and you have many times, and I have too, with pneumonia, you're going to pretty aggressively try to diagnose, because you got to know what antibiotic to treat them with. It's not just here's a pneumonia, let me just take a shotgun and fire at the x-ray. You want to know exactly what bug it is, because you can lose that patient by not doing that, certainly in patients that are debilitated to begin with, who typically get pneumonia. So I think we need some answers to this right here, because it's important, because this seems to be an outlier as opposed to what happened. And I think the reason it would give me some comfort is if those levels were normal, then maybe those standards need to be changed. And I think the other thing, I didn't know how 30%. A lot of times things are arbitrary. How many liters of fluid went on the space shuttle? Somebody said 4, and that's how many there are. So this 30%, was there any basic science in that said this was a threshold that Are there any studies that document?
Yeah, there has been a study that talks about this and documents it, but I will reiterate what I said before. The science for almost everything we've talked about today is weak. Most recommendations are not strong for any of these because the science just isn't there. So, which is again why we're reviewing the literature again, and I'm sure that new guidelines coming from the CDC will have also reviewed all the literature.
Just one more question for you all and Dr. Hicks. Is the CDC's recommendation zero tolerance?
Yeah, that's correct.
So that's the standard. That'd be easy. I could make that vote this afternoon. I yield back.
Thank you, Dr. Rowe. Mr. Waltz?
Thank you. I'm going to kind of piggyback onto what Dr. Rowe said. I think that's really the bigger issue here. This is a much broader issue. Dr. Jesse, I appreciate your point on that. Obviously, we come back again to this issue of zero sum. I don't know if there's ever been a congressional hearing on private sector hospitals and their infection rates, but we heard on this. We're going to hear from some experts next that I think is going to help clarify some of this and go through it. But can someone tell me, is it kind of just personal choice, or is it cost involved? Well, why chlorine dioxide over copper silver ionization? The research I look at, and some of the people who wrote the research are sitting behind you, seems to indicate it's kind of up in the air. Is there a reason? And what do the other local hospitals? You just mentioned it a little bit, Dr. Hicks. They use the chlorine, or excuse me, the copper silver ionization.
So I think it's a really important question because there really is no one-size-fits-all solution to controlling this problem, and it's a very difficult problem to solve. Someone mentioned recently that it's like trying to get rid of houseflies, but obviously a much more dangerous type of situation here. So it obviously needs to be taken very seriously. But there are different disinfection methods to try to address it in the environment. The two that are currently EPA approved are chlorine and chlorine dioxide. And so those are the two EPA approved methods for disinfection of water systems. And it would be nice, ideally, if we can build the capacity within our program and work with EPA. We would really like to take the opportunity to evaluate all these different approaches to legionellosis prevention and do head-to-head studies.
Because I'm interested in, from a CDC perspective, I understand, and it's we all want to reach zero, we want to do this, but there are considerations based on cost, what you have the capacity to put in place and things like that. And I would get back at this issue of preventability. I mean, I think it's important, but this is a tough one with medicine. And maybe it's because of the successes we've had that folks want to see that, and we should strive for zero on this. But from a preventability case, the only way to prevent that they would have got this there is for them not to enter the facility. Same way to prevent automobile accidents, if no one drives, that's the only certain way you can do that. But the cost of not doing that, the cost of a veteran not going to the Pittsburgh hospital with chronic chest pains because of this, I think we have to be very careful on we want to strive for that zero preventability, but I think there's always a squeezing of the balloon, if you will, that something happens somewhere else. And the same thing on, are we putting our money in the right place? Are we testing accordingly? Are we mitigating circumstances where they should be? Because I'm thinking, I was just mentioning this, I would have to think if there were any test at all that showed anything at the Minneapolis VA, all kinds of red flags would go up, because if I'm understanding it right, that's very unusual that I don't think they would get a test. Am I right on this, where we're going?
So, as I said, there are some VAs whose municipal water supply is treated with monochloramine that don't have a problem. It's almost pointless for them to test. And if they did and something popped up, it would really raise a red flag. There are certain parts of the country, likewise, never had a case, never tested it positive in the water, so to continue testing would not make sense. But again, the management of Legionella is not a single thing. It is surveillance of both the clinical cases, and this is the only thing I know of where we also monitor environmental cases. We monitor pertussis, we monitor TB from the clinical incidents, but in this case we're also monitoring the environment, and we do that most rigorously in cases, in areas, in hospitals where we have historically had a problem or we have ever identified cases. And the strategy then is built on the individual hospital and their history.
Dr. Hicks, do you happen to know if CDC's budget is cut under sequestration or not?
I don't know anything about the budget, but
I'm just curious, as we as a nation have these conversations, I'm guessing, and I'm seeing this monitoring and this remediation is a very expensive process. Am I right to say that?
Yes.
Now, my question is that it's worth it, because I agree that no veteran should go there, or no patient should go to a U.S. hospital, but I think this broader issue, and if there's specific issues that we missed at a high chance hospital or a high rate hospital, we should work with that. But I think this gives us an opportunity, Mr. Chairman, to take this to a broader level about what is CDC's role, what are those standards, because I'm baffled too by the 30% thing, and I understand that at some point you have to set a number, but I kind of agree with Dr. Rowe that if it's causing it, that's where it should be. But I yield back. Thanks, Mr. Chairman.
Thank you, Mr. Walls. Dr. Benishek? Mr. Rothfuss?
A question on the copper silver iodinization. Do you have confidence today that process, is it still being used at VA in Pittsburgh?
VA Pittsburgh took the copper silver offline. Again, the major sway point was that at the time the CDC looked at their samples, the copper and silver ion levels were within range, and they could still grow Legionella. And again, this is a system that had worked for many years of suppressing Legionella. It doesn't eradicate it completely, but it suppresses it. And clearly, at this point in time, something different, something had changed. So now it is offline, and they're using what's called a chlorine drip to increase the chlorine level running to the tap heads to control that. And again, that's pending a more long-term and permanent solution. As Mr. Moreland mentioned, that's going to include putting scald-free taps in place for all the taps and showers, and that allows us to raise water temperature up, which also mitigates growth, and a more permanent solution, whether it's monochloramine, whether it's chlorine dioxide, we don't know. We have to look in that. We will make that decision based on the best advice of both internal and external experts and advisors.
How recently was the chlorine drip initiated?
It was initiated in November, yeah.
Have we done testing since?
So they did, when the CDC recommendation was they did the heat remediation, they followed that with a hyperchlorination. So that's like chlorine to pool level, you can't drink it. And then now a chlorine drip that maintains a lower but drinkable level of chlorine in that system.
When was the last time we tested for presence of Legionella?
They've been testing every 2 weeks, and the system's been clear. The plan is to continue that testing for at least 90 days, and then in consultation with CDC, we'll change whatever that testing strategy might be.
Thank you. Thank you.
Thank you so much, panel, and I just want to note again for the record that the individuals that were requested to be here and testify that were directly involved in this particular incident are not here today. Mr. Murphy? Okay. Let's bring the next panel. I now invite the second panel to the witness table. On our second panel, we will hear from Dr. Victor Yu, Professor of Medicine at the University of Pittsburgh, Dr. Janet Stout, Director of the Special Pathogens Laboratory, Mr. Aaron Marshall, Operations Manager for Enrich Products, Inc., Mr. Steve Shira, Chairman and Chief Executive Officer of Liquid Tech, Incorporated, and Ms. Kathleen Dahl, President of AFGE Local 228 at the Pittsburgh Veterans Affairs Medical Center. All of your complete written statements will be made part of the hearing record. Dr. Yu, you are now recognized for 5 minutes.
Mr. Chairman, I was Chief of Infectious Disease at the VA Medical Center for almost 30 years and received superior performance evaluations for each of those 30 years. And I also want to say that the Pittsburgh VA is a great medical center. Health caregivers and the services there are extraordinary. However, the upper layer of bureaucrats causes, and this I think is true for many hospitals, the bureaucrats causes some problem. But as I was listening to this today, where you say, hey, it's not 30%, so you don't have to do anything, they had 16 cases with 5 deaths. And maybe if there's a patient who dies of Legionnaire's disease, maybe you should pay attention to that one and not whether or not it's 30%. So that's just a parenthetical statement. I was also chief of the Special Pathogens Lab, and the Special Pathogens Lab was established under the aegis of the VA Central Office in the early 1980s because of the massive number of outbreaks, not only the American Legion outbreak, but outbreaks at Wadsworth VA Medical Center, 200 cases, 4 years. VA Medical Center, 100 cases, 3 years. Togus VA Medical Center, 50 cases, possibly in 1 to 2 years. And based on that, our lab was designated as a special reference lab, and then was formalized under the previous director before Mr. Moreland came as a special clinical resource center for the VA. And one of the things that we were supposed to do is, because of the prominence of our lab, we were doing not only cultures for the entire VA medical center, but for all academic medicine centers in the United States and in public health agencies that would send specimens just because we were the only lab that was doing that. And therefore the VA thought we can charge money for it. And 3 special clinical resource centers were set up. Yale for virology, Florida for Texas for fungi, but the most famous one of them all became the Pittsburgh VA Special Pathogens Clinical Resource Center, and we did the cultures for the entire VA. Now, we have, our accomplishments, I think, are a matter of record, and we've received many honors, not only from NIH, but most of them have come from the VA, from international societies, and the one that I treasure the most is from the American Legion. Here are a few of the key things that were done. Janet Stout discovered that the source of Legionella in the hospitals was not in the cooling towers. It came right from the drinking water of the hospital, published in the New England Journal of Medicine in 1982. But 1976 was when the outbreak was occurring. So these outbreaks are occurring all over the world, actually, at this time, and they started to look for cooling towers, and it was right in the drinking water. But that discovery was also meant another thing. If we know where it is, and it's right in the hospital, we can prevent it by going after it in the hospital. And this is a sore point between we and CDC, because we endorsed the drinking water concept and CDC endorsed the cooling tower concept, and it now turns out that we have a pretty good record now. And so now we're able to prevent it. And so we and the University of Pittsburgh Department of Engineering instituted a systematic process where we would try innovative ideas, trying to figure out how could we get this organism out of the water distribution system. Dr. Hicks was so shocked that this organism was in there since 1982, and she's relatively new to Legionella. Every hospital, this is be it Barcelona, Spain, or Palo Alto VA, or all the VAs, that organism stays in the hospital for the rest of the lifetime of the hospital. And Columbia Presbyterian wondered maybe they should tear out all their pipes. They did that accidentally by using chlorination, and then would later switch over to copper silver. So the organism, it gets into the biofilm, which is that thick film in detritus, the calcium deposit, and it stays there. And so you can suppress it pretty easily, but you don't maintain the system, that organism will come out. And so every hospital, be it Barcelona, Spain, United Kingdom, when it comes out, it's the same organism by genotyping that was there 30 to 40 years ago. That's an actual fact that almost all Legionella experts know about. Now, this is what we in the Department of Engineering did, and these were engineers that were graduate students and professionals in engineering. We were the first to evaluate all of these innovative technologies. The first one we tried was superheat and flush. There's some problems with that because it's tedious. The second one we tried was chlorination. And so many hospitals instituted chlorination, and we did the first controlled study published in the Lancet in 1985. So we know chlorination. And there's some problems with chlorination, but by the early 1990s, we decided to try another modality called copper-silver. That modality is now, and you have a list, all the great medical centers in the United States, almost all of them have copper-silver today. And that can be discussed later. We were the first to introduce chlorine dioxide in the United States, the second, but the first one to evaluate it in the controlled studies. The chlorine dioxide had failed in the United Kingdom, but we found out that it could work if you did some certain things, and that will come out. Monochloramine, which Dr. Jesse mentioned, we're the first in the United States to institute monochloramine. That is our study and is undergoing evaluation. Now, we also developed all of the microbiology methods. You don't have to use a liter or 100 liters, and I won't go into that. Every one of the culture media used for isolation from patients or from the drinking water, we developed that media. That media is commercialized. We gave out no patent. So all of the culture media that all the hospitals use in the United States today, almost all of them are based on the
I think, I'm sorry,
formula.
but we're running out of time. I wonder if you could just conclude with your testimony, and we'll get to the rest of the panel, and then we'll get to questions, and you'll certainly have an opportunity to amplify things in questions.
Okay, well, the most important thing that we did, we came up with the antibiotic that resulted in over a 95% cure. And we tested all the antibiotics for the pharmaceutical industry, and based on that, we recommended that certain antibiotics come out. One is called azithromycin, which is the Z-Pak. What is used in hospital is the more powerful IV form. Then the second one that we came out was levaquin or levofloxacin, and that one led to almost no mortality. So that is the one point that we want to make. You can not only prevent it from occurring in the hospital, if it occurs, you can save their life by giving them the antibiotics. So from 1996 to 2001, 21 consecutive years where there was not a single case of Legionella. But if there was, they would have lived. And our inspector in the American Legion, because when they closed the special pathogens lab, they warned the VA that maybe this is not a good idea for the patients. And Brad Miller, Congressman Brad Miller, in the 2008 hearings, made this prophetic statement. He says, Dr. Yu, we will never know how many patients died because of what the VA did. But it turned out Congressman Miller was wrong. We did know. There were 5 at the Pittsburgh VA Medical Center. A preventable disease by prevention and preventable with antibiotics.
We'll come back to you with questions. Dr. Stout, you are now recognized for 5 minutes.
It says only 4 minutes here on my clock, sir. 4:50. I only have one sentence to make. If I could just make it, because I do have 10 seconds on my clock. Oh, okay.
Okay. I want to thank the House Veterans Affairs Subcommittee on Oversight and Investigation for holding the hearing, Senator Casey, Congressman Doyle, and Murphy for requesting investigations into the Legionnaire's disease outbreak that occurred at the Vision 4 healthcare facility in Pittsburgh. The affected veterans and their families deserve full disclosure from the administrators at the University Drive and Hines facilities in Pittsburgh. I'm a microbiologist trained in environmental and clinical microbiology and hold a master's and PhD degree from the University of Pittsburgh Graduate School of Public Health. I'm testifying today as a subject matter expert on Legionnaire's disease. My 30 years of research in the field of Legionnaire's disease provides me with special knowledge about Legionella bacteria, the methods to control it in hospital water systems, and the methods to investigate possible cases of hospital-acquired Legionnaire's disease. I also have intimate knowledge of the procedures and practices that were established at the Pittsburgh VA facilities in response to previous outbreaks at those facilities, and this includes methods and scheduling for monitoring or testing Legionella and the copper and silver ions, maintenance of the ionization system, and the microbiological methods used for detecting Legionnaire's disease both in patients and the environment. The approach to prevention of Legionnaire's disease developed at the Pittsburgh VA stopped an epidemic and resulted in groundbreaking discoveries in case detection and water system disinfection. These procedures were followed by other facilities to prevent the disease, including guidelines in Pennsylvania, Maryland, New York, and the Veterans Healthcare System. Through our efforts, Legionnaire's disease was controlled at the Pittsburgh VA. In fact, as we've heard earlier, there were no cases of hospital-acquired Legionnaire's disease for over 10 years. So the question is, how did this happen? You'll hear excuses and diversions trying to shift responsibility to methodology, policies, public health authorities, and even blaming the disinfection technology that protected the VA patients from 1994 to 2006. Don't be distracted. The failures to be investigated include, 1, failure of the Pittsburgh VA to recognize they had an outbreak and take preventive actions. The delay may have contributed to additional cases and deaths. 2, failure of the VA lab to detect Legionella in the water system of the VA University Drive. This is likely contributed to delay in detecting the outbreak, and this failure was due to lack of knowledge and experience, a problem that was brought to the VA Inspector General's attention in 2009. 3, failure of the VA to operate and manage the copper-silver ionization disinfection system. And finally, failure to communicate with physicians, staff, patients, and families regarding the increase in cases. The delay in alerting physicians may have contributed to additional morbidity and mortality. The only way an outbreak of this magnitude could have occurred is if the water system of the Pittsburgh VA had become heavily contaminated with Legionella. The environmental testing performed by the VA microbiology laboratory should have detected this increase. At the time of the 2012 outbreak, reports from the ionization manufacturers indicated that the copper-silver system monitoring, when performed, did not meet the suggested target levels, and that documentation of this condition began as early as the spring of 2012. We really need to know what were those results of testing for copper-silver in 2011 and 2012. Based on my experience and after review of the CDC report, I offer the following comments and recommendations. The Pittsburgh VA Microbiology Laboratory failed to detect Legionella in environmental samples due to inexperience, lack of knowledge, and use of outdated methods, a problem that, as I said, was brought to the attention of the Inspector General in 2009. However, they continued to perform testing for other VA facilities. The Pittsburgh VA Microbiology Laboratory should discontinue this process of offering testing to other VAs, and they should notify those facilities that the results of that testing may be inaccurate. The CDC is invited to assist facilities in dealing with outbreaks. As their guest, their recommendations will not assign responsibility, but will merely suggest changes in policy, which we've heard today. It will be the role of this committee to hold people in administration accountable for the failures that led to this outbreak. And accountability needs to come from the top down, not the bottom up. The VA Legionella directive and public health policies should not be rewritten due to the management failures of this facility. It was the responsibility of the Pittsburgh VA to be current in knowledge and vigilant in following the policies and procedures that were already in place. The system isn't broken, so don't fix it. Finally, the VA management does owe an apology to the physicians, staff, patients, and families regarding the delay in informing them that there was an increase in cases and that an outbreak of Legionnaire's disease was suspected. Thank you for your attention. I'm happy to answer any of your questions.
Thank you, Dr. Stout. Mr. Marshall, you are now recognized for 5 minutes.
Mr. Chairman, committee members, thank you for inviting me to testify today. My name is Aaron Marshall, and I am the operations manager for Enrich Products. Enrich supplies copper-silver ionization systems for the control of Legionella and potable water systems. I am also a veteran of the U.S. Army, having served honorably for over 4 years. And my father was also a veteran who received exceptional medical care from the VA health system for many years and currently receives that same exceptional care in West Virginia, VA health system. The intent of my testimony is to provide information that will contribute to a better understanding of what transpired at the VA University Drive campus in Pittsburgh, and to provide supporting evidence that copper-silver ionization, when applied properly, is an effective method for controlling Legionella in potable water systems. There are two ways copper-silver ionization systems can be implemented. The first is a proactive course, and the second is a reactive course. In a proactive course, a copper-silver ionization system is installed as a preventative measure. In these facilities, there is no confirmed cases of Legionnaire's disease or legionellosis. The facility may not even test for Legionella. In a reactive course, a facility has either confirmed the presence of Legionella in the water through testing, or the facility's potable water system is suspected or implicated as the source of Legionnaire's disease or legionellosis cases. In response, a copper-silver ionization system is installed temporarily or permanently. Once the desired results are achieved through the reactive course, the equipment is either removed or continues to operate in the course's transition to the proactive regimen. The difference between the two rests in the course of actions recommended, and they are quite significant. In the proactive course, lab monitoring for copper and silver ions is recommended monthly. Flushing of non-used fixtures is recommended monthly also, and Legionella testing may or may not happen. In the reactive course, lab monitoring for copper and silver ions is performed weekly. The facility institutes a controlled flushing program such that all fixtures are flushed weekly, and Legionella testing at day 15 and day 30 is conducted to determine the course's effectiveness. This reactive course has been successfully implemented at numerous facilities, including the Cleveland VA Medical Center, as well as facilities in Pennsylvania, Florida, New York State, North Carolina, and Illinois. I'm here today because in June of 2012, at the request of the Pittsburgh VA, I personally was called in to perform a review of the copper-silver ionization system and its operation at their facility located on University Drive in the Pittsburgh neighborhood of Oakland. I was asked to make recommendations that would help to improve the functioning of their existing equipment provided by Liquitech. And they're just another supplier of copper-silver ionization equipment. Before submitting my general recommendation report on July 6, 2012, I visited the VA University Drive campus facility 3 times. The dates were June 4th, June 21st, and July 2nd. There was no charge to the VA for these visits or for my report. During my visits, I personally viewed the 4 different locations where the Liquitech copper-silver systems were installed. I was provided access to the site records from January 2012 until the end of June 2012, and the lab copper-silver data from June 2011 through July 2012. I requested but was denied access to view the Legionella test results. During 2 of the 3 visits, I had separate meetings with infection control and engineering and maintenance personnel. The 2 meetings covered similar topics. Those major topics were system maintenance, frequency for monitoring of copper and silver ion levels, and criteria to determine site test and lab testing locations. In each of the 2 meetings, I covered the enriched recommendations for the routine and reactive course of actions, as described earlier. Had enriched products been aware of the presence of Legionella or legionellosis cases at the VA University Drive campus, we would have definitely recommended implementing the reactive course immediately. Sometime in November of 2012, Enrich learned through the media that in fact there were reported cases of Legionnaire's disease at the VA University Drive campus, and that there were deaths as a result. In addition to the reporting of the outbreak, the media, through quotes from the CDC and others, offered doubt on the efficacy of copper-silver ionization. Copper-silver ionization is an effective method of controlling Legionella bacteria. However, in order to maintain its efficacy, the installed system needs to be properly maintained and regularly monitored. Another important point to note is that in order to definitively know where the source of Legionella or Legionnaire's disease cases came from, testing must be conducted. Often it is assumed automatically that the source must be the hot water system in a facility. We have found a number of times that sources were other than hot water, and more recently, they've been identified from water features in ice machines. In conclusion, during the short time that Enrich worked with the VA University Drive campus through today, the VA has not shared its Legionella testing data or results with Enrich. If the investigation concludes the potable hot water system was the source of the outbreak, there is no question that regular testing could have detected the presence of the bacteria and that the reactive course of actions would have been implemented. At least we would have recommended it immediately, likely minimizing the risk of the outbreak. We hope to have the opportunity to work with the Department of Veterans Affairs in the future in an effort to reduce this risk at all of their facilities. We also hope to establish a dialogue with the CDC where we can share data and information demonstrating the real-world experiences and successes of copper-silver ionization. Thank you, Chairman, and I yield the remainder of my time.
Thank you. I'd like to thank the subcommittee for allowing us to try to assist in devising, learning, and understanding what goes on in an environment of care and dealing with pathogenic bacteria such as Legionella. I'm going to somewhat drop my authored statement here a little bit because I was so shocked at some of the things I heard. First of all, much of what I have to say, which I will try to state where we physically were at the VA and 2 courtesy visits, but basically what Aaron has stated is in fact the gold standard, if you will, for how to maintain and operate a copper-silver system. It just requires, okay, a partnership between you and your client, your customer. We have more than 1,400 systems installed for over 20 years. We know how to collaborate and work on the issues, as Aaron has just analyzed, as well as what we were. We never got a call from the VA to come in and help. We had not heard from them for years. We collect a history data log sheet on every system that we try to have communications with the customer that logs their copper-silver, logs their Legionella, logs their ICPs, logs the cleaning cycle. We had 0 on the 4 sheets for the 4 systems at the Oakland VA. We prompted a courtesy call back in December of 2011 where we went unsolicited to simply see if we could regenerate some dialogue with the facility. During that visit, we were actually informed that there was potential problems with Legionella. They had sporadic shows, low levels, but we also were able to see in the walkthrough that the systems were not being maintained clearly. The issues of maintenance of the flow cells and also the settings. The systems that are installed at the VA have what is called proportional control. They increase and decrease. There's no valves. There's no switching around as was indicated. It is a computer that actually reacts instantaneously to the water demands on that hot water loop. So we are giving you more ions or less ions according to that water demand. We are also able to remote monitor that system and collect data minute by minute of what those systems. Every one of those 4 systems at the Oakland VA were capable of having such remote monitoring. They chose not to do it. Copper-silver as a disinfection technology has been, I would venture to say, more popular, more successful than chlorine or chlorine dioxide. We would be happy to contribute as much data and information to what those site visits we learned. One was, frankly, in April, where 3 of our people were visiting with a Dr. Muter, a Patty Harris, a Rodney Getz, all of whom admitted that the systems weren't being maintained as they should. One of the reasons for that was there was a gentleman who was in charge, was out on disability, and therefore the few people left didn't really know what to be doing. We offered that we would jump in and do whatever we could possibly do, give them advice, give them the ability to remount. We told them we'd clean the cells if necessary. We never got a response. Nobody ever came back to us. So what has occurred here is clearly a lack of true concern for the veterans that are being treated at that facility. Because since 1993, where a research study was done by Dr. Yu and Dr. Stout, and were able to control the Legionella after trying chlorine dioxide, heat and flush, they were able to utilize the system we gave them in 1993 and affect the right results. One last point, as a matter of more chemistry than technology. If you are going to heat and flush, if you're going to hyperchlorinate while you're trying to use a copper-silver system, you might as well turn the copper-silver system off, because you're throwing out all the ions when you are doing those flushes in operation. So, which we were never told. We had no idea they were doing these things. There are steps and actions you can take that could potentially work, and you want to do heat and flush, that's okay. But we should know what you're going to do and collaborate how you're going to get the ions back up to where they're at. Thank you.
Thank you for your testimony, Mr. Shura. Ms. Stahl, you have 5 minutes for your testimony.
Chairman Kaufman, Ranking Member Fitzpatrick, and members of the committee, thank you for the opportunity to testify today. My responsibility as an AFGE local president is to present the safety concerns surrounding the current Legionella outbreak. Notification on November 16, 2012, that the hospital was going to water conservation due to elevated water samples for Legionella really wasn't heart-stopping at that moment. As a nursing assistant that started in 1994, became an RN in 95, I was often told, don't drink the water, because Legionella had been in the pipes for a very long time. Hospital employees are surrounded by exposure risks every day, be it TB, tuberculosis, the flu, hepatitis, MRSA, C. diff. But hospitals use isolation precautions, immunizations, masks, and other preventive measures every day to reduce these risks. Why would Legionella be any different? It became heart-stopping when I began to piece together media reports, employee reports, emails, and previous notices of emergency heat and flushes and problems with the pipes. I began to question exactly how long did the VA know about this and why weren't preventive measures put in place. I grew concerned and requested to meet with Director Terry Wolf. She wasn't on campus at that time, but promptly arranged a meeting with her leadership designees. Following that meeting, I really began to feel that employees were simply collateral damage, not even considered to be harmed or at risk. They weren't provided protective gear. They weren't provided notification to take precautions. I had employees that stopped me in the halls coming to our office and calling on the phone with concerns that they had assisted with the flushing and they were not provided masks. Could they get it? How do I get it? Should the hospital be shutting down? They were in the hospital with pneumonia only 4 weeks prior to the notification. Was it related? Reports started coming in back in July of August of being hospitalized for 5 to 6 weeks. We instructed them to report to employee health, only to be turned away. AFGE immediately notified VA leadership that employee health had been turning the employees away, and they immediately corrected the problem. But the employees, when they did go, they were told that they did not need a urine antigen test to see if respiratory illness was related to Legionella. After all, it was flu season. Legionella can be contracted in your homes. Or they were told it was too late to get tested because it was only good for 30 days and that they were not at risk. It only happens to immunocompromised people. people that are sick. Don't forget our employees. They're an aging population that are over 50. Some of them smoke, ex-smokers. Some of them have diabetes. Some of them are on chemotherapy and they come to work. They're immunocompromised, so they were at risk. OSHA guidelines are clear, and AFG shared them with leadership. When you have 2 or more positive cases of Legionella within 30 days, this is considered an in-progress outbreak. The VA should be screening employees who are absent 3 or more days in a 6-week time frame in relation to these positive cases. This would have allowed early identification and information to employees that they were potentially exposed and provide the opportunity for a voluntary response. This would have allowed for timely testing and linking, or even better, ruling out Legionella exposure. Please don't forget the employees. Many of them are veterans themselves. They work day and night to flush these pipes to reduce the Legionella without personal protective equipment, and were not even instructed that they needed to. They were not screened or timely tested for Legionella as they should. They took care of our veterans during this time. They have a tough job toileting and bathing patients that may or may not have control of their bodily functions. Imagine doing that without running water. They clean patients with hand wipes and small bottles of drinking water. There's pressure to not only hygiene the patients, but to prevent cross-contamination of other infectious diseases. It's the law and VA policy to maintain a safe environment at all times. We can do this by developing stronger policies that deal specifically with water interruption related to the existence of Legionella in our pipes and the construction. We can do this by better training to those in the plumbing shop. Not all of them are plumbers. We can do this by having awareness and implementation of OSHA guidelines when something occurs and protect the employees that provide to our veterans. Our director, Terry Wolf, is genuinely concerned about the well-being of the patients and the staff. I'm confident that she's going to find solutions that prevent something like this from happening again. But the union needs to be part of this process in educating the employees and providing safe environments. It's the law and it's common sense. Thank you.
Thank you, Mrs. Dahl. Dr. Stout or Dr. Yu, in your professional opinions, were the deaths of the 5 veterans preventable?
Go ahead.
Yes, absolutely. I write the chapters in Harrison's Textbook of Medicine, the most widely used textbook, up to date, and all the infectious disease texts. And one of the points I make to physicians and medical students, that the mortality from Legionnaire's disease with these new antibiotics that we brought drops the mortality close to 0. So it doesn't have to be that we've knocked out the 40% mortality that we saw in hospitalized patients. So how did these patients die? First of all, we showed you could prevent it, 21 consecutive years. The only way that they could have died was they didn't get the antibiotic, or they got it way too late as they were dying. And the 30% has been mischaracterized. It isn't that you ignore everything with 30%. As soon as it hits that danger point of 30%, you go into red zone. Essentially what you do, and this was done, and we monitored this at the Pittsburgh VA, the infection control nurse looked at all the chest x-rays just to see if somebody with congestive heart failure may actually have Legionnaire's disease, and then to see if they received the Legionella test. The culture is actually the best test. That disappeared after we left. The urinary antigen picks up 80%, so another 20% were missed. Everybody in the ICU has to get a culture. So as soon as Legionella re-entered the water supply, probably as early as 2007, because that was the first case after we left, and certainly after 2011, where you now have 16 cases, you go into red zone alert. And this is what was done. The fact that Legionella had recontaminated the system was not communicated to the emergency room physician, the hospitalist, or the intensive care physician.
So it was preventable. Dr. Stout?
Well, I would have to completely agree with that. And all you have to do is look at the history at the Pittsburgh VA to know that it was preventable. And I really don't know how much more evidence you need. We were using the same system. We were vigilant about monitoring for the ions and the cases. In fact, one of the things that's noted in the CDC report was the absence of the culture of respiratory specimens of patients that were diagnosed by the urinary antigen test. Well, when we were there, even if the physician didn't order a Legionella culture of the sputum, we made sure that that sputum that he ordered for staph, strep, Haemophilus was in the refrigerator and held for 7 days. And we could go back to that sputum and recover Legionella and do the matching. And, you know, these are things that should have been done there, should have been continued in our absence, and clearly they were not.
Okay. Mr. Marshall, was the Pittsburgh VA forthcoming with information that helped your company work with it better to detect and prevent Legionella in its water system? Please.
Mr. Chairman, no. In fact, as I mentioned in my earlier testimony, Enrich never received an indication either verbally or written that there was a Legionella issue or Legionella positivity in the water at their hospital. So the way that I perceive it is that we weren't able, as an outside source, to do our job as effectively as we possibly could.
Thank you. Mr. Shara, did your company brief the VA in December of 2011 about poor results related to the Pittsburgh facility's water?
Well, first of all, we did not have any results as to what was going on. The only thing that actually was shared during that visit was that they were experiencing problems and had some issues. We never, either previously or even during the visit, have the opportunity to actually do copper tests or copper silver tests, or the ultimate test, of course, is the Legionella validation. So we were just operating from what we were told as to what was going on in their environment of care, which it now sounds like there was a lot more going on than we realized.
Thank you. Ranking Member Kirkpatrick.
Thank you, Mr. Chairman. Let me just say this is an excellent hearing. I thank you very much for putting together these panels. Ms. Dahl, do you feel that you're being treated differently by the VA since you have assisted this committee?
I probably wouldn't know that until I return to my place of duty.
Were you told that your reference to 4 employees who had respiratory illness to the media could be a HIPAA violation?
I was advised that I was close to a HIPAA violation. I have quite a bit of awareness as my profession as a nurse to know that I did not provide any identifiers, but I was told that by leadership that I was close to it and cautioned me when I speak with the press.
Thank you for your testimony today.
Thank you.
Mr. Shira, you indicated that the copper-silver system was not being properly maintained. What signs pointed you to this conclusion?
Well, the systems that we had provided to them, first of all, were to have attachments of flow meters so that the automatic computer can react to the water demand. And those were not properly installed, or in most cases, not functioning. We were able to see that the ionization chambers, when sitting or removed from the system, were heavily caked with scale, which will prevent the amount of appropriate number of ions to be admitted. Also, the systems were being run in a continuous mode opposed to what would be a proportional control mode.
Can you describe for us, what should be in place to have the proper maintenance for these copper-silver systems? What would be the proper way that they should have been handling this?
Well, basically what we do is, first of all, we do a startup and training, which typically will take about 3 hours. We provide the facility with a educational binder, a 3-ring binder, which literally walks you through what the whole startup and training is about. Then we work with infectious control to find out how many distal sites they and the facility would like to test for the Legionella, the frequency of that testing. Also, we recommend, because the data can come up and we move it around, that you stay at, for 1 quarter, the same sites, so we can track to see exactly if there's any anomalies in what is going on. One of the key factors in paying attention to your environment of care on any system, but a copper-silver system, of course, in our particular, is knowing whether there are situations where rooms and distal sites are not being used. They actually start to create a dead lake and are capable of generating Legionella, even though our system's installed and operating. That's why we have a 3-page protocol for flushing of inactive sites in the operation. And then the most important thing is share the data. Tell us what's going on so that we can contribute. And if it's remote monitoring, we can actually adjust the system remotely. So we'll know exactly what your water demand was, what your amps, your volts, and how the system may be adjusted to be either more aggressive or potentially turned down. But it's data collection and consolidation of that data to be able to have a true environment of care view.
And so it's constant maintenance, and that's something that you thought was missing at this particular hospital?
That's correct.
Thank you. I yield back the remainder of my time.
Thank you, Ranking Member Kirkpatrick. Dr. Murphy?
Mr. Marshall, you said you tested some of the systems within the hospital. Am I correct in that?
We did not, Enrich did not test any of the systems. But what we did receive from the Pittsburgh VA was site records and lab copper-silver data, which is what...
Did you receive lab copper-silver data that said the readings were outside of their acceptable ranges?
Yes, in fact, as I look at them now, the one system, it's why I also like to know exactly where the cases happen.
Okay.
Because then we can, but in one system in particular, AA114, the levels for both copper and silver were below from June 2011 until April 2012.
Did you make a recommendation to the hospital they should take some action?
Yes, of course.
Did they take any action?
Well, the recommendations I made in my report was more or less based on a routine monitoring. And again, if I would have known more...
If you would have known there was Legionella cases, you would have done something differently?
But even at that, I still requested increasing the frequency of their lab copper-silver testing, simply because with a history of low levels, that would have given us a better opportunity to make more timely adjustments.
Okay. Now, Ms. Dahl, it's been stated that whoever was supposed to more or less manage, maintain, monitor this was out on disability. Were there sufficient staff within the VA system who had expert knowledge of how to manage and monitor this system available? Consistently throughout time?
I can only speak of this year is my first year as a local president. I've learned things that I didn't know before, regarding boiler plants and the plumbing and things of that nature. So I'm not an expert to state. But I do know that there's been consolidation to build efficiencies in staffing. So we've combined duties to fit into the...
But I would something like this. Is this something that requires, for someone to work on these systems, requires some level of experience or training, or can they simply walk on the job and look at a chart and do it?
They would need some form of training to know what to do with the information.
But we understand that the person who normally does this was out on disability, and so were other sufficiently trained staff available, to your knowledge, if you don't know?
To my knowledge, they had 15 minutes of training, what they reported to me.
All right, thank you.
Can I comment on the backside of that?
Yes.
Just to point out that the VA's own policy indicates that there should be 2 fully trained individuals on how to operate the system at all times.
Are there 2 fully trained individuals on how to operate the system at the VA? Do any of you know that? If you don't know...
I don't know that.
Michelle, I want to read you something from a timeline the committee has here. It says, Liquid Silk reports, this is April 16, 2012, that they completed a site visit with contractor regarding new system as well as facilities and infection prevention regarding existing systems. The contractor, Tomco, and BMS people were having issues connecting the systems up. Nikhil and John resolved these issues. LTI team visited each system and met with IP and facility management. We were told that the gentleman who normally takes care of our systems was out on leave or disability, and the remaining maintenance staff did not know how to maintain the systems. Furthermore, they had not been doing weekly testing or regular maintenance. When the LTI team went into the maintenance shop, LTI personnel encountered Oakland VA staff fabricating, as in falsifying, handheld copper records. Upon visiting the systems, there was obvious evidence that the systems had not been regularly maintained and flow meters were not working. Infection prevention said they had some dark water issues. Sir, to your knowledge, is it true that someone was fabricating this data?
I believe so, yes. We queried the 3 people who were on site. 2 were very experienced, knowledgeable engineers, and the term of whipping copper levels is where you simply to respond quickly.
How did you query the people? And please put your microphone right in front of you.
I'm sorry.
That's okay. How did you query these staff who someone physically observed someone writing down false information?
These were 3 of my employees.
And your employees saw someone else writing down information?
Correct.
Was it from lack of training? They didn't know what to do? They didn't understand how to write down the data? Did you query to find out?
No. It was somewhat embarrassing, so they didn't even comment.
Was that brought to the attention to the VA or to anybody else to find out what?
Unfortunately, no.
And because of this information was registered, did it come out then that the copper ionization levels were acceptable?
I believe that's what was being documented on the sheet. Yes.
You know, I got to tell you, a few years ago when I joined the Navy, I did it to try and help a lot of our wounded soldiers when they were coming back and coming to hospital. And what I'm hearing here is deeply disturbing, that either we have weak or absent standards of what we should be doing, weak adherence to standards, or some incredible negligence that led to the death of 5 people. I yield back.
Well, thank you. First of all, my comments here is that some of the accusations that were made here, I'm going to put in for the record, Mr. Chairman, that I think these witnesses should have been sworn in or still should be, because the accusation of knowledge of a crime of this magnitude is a pretty serious accusation. And my question is now is, are we going to get names? Are those people involved in this going to have recourse? So for the record, I would counsel that. With that in mind, witnesses, we all here want to get the best care for our veterans the best way possible and find out what's going on. But there's been some pretty serious accusations. If they prove true, someone should be prosecuted, someone should go to jail. But I hope all our witnesses understand to make such a statement in this setting holds very serious consequences. So with that, and not to further the stereotype of passive-aggressive Minnesotans, I just do have a couple questions. I did dovetail on that, Ms. Dahl. I concern for your workers. The government, a government entity should always set the standard in terms of workplace safety, workplace protocols that are in place. I myself do not know. That's why I think Dr. Murphy's questions were correct. Were we following protocol? Were we putting your people in the position? I think that's something this committee needs to follow up on, and I pledge to you that's what we'll do. Mr. Marshall, do other companies share their data with you that you have this installed with?
Well, first of all, this isn't our equipment.
Okay.
So, but yes.
Are you on contract to the VA to maintain the equipment?
No.
Okay.
No, we service equipment all over North America, and we also sell equipment all over North America. This wasn't our equipment, but they were familiar with us helping them or other facilities in the Pittsburgh area and asked us to come in and just put a new set of eyes on it.
Okay. Mr. Scheer, you said that no one told you or whatever. Are you under contract to the VA to provide that type of counsel? So were you prepared to do it pro bono? Are you prepared to do that today, to go in there pro bono? So if they choose to use you, though, they're going to have to pay you, and we're going to have to go through the contracting procedures that are put in place. So it would not be unusual for them not to share that data with someone who's looking for a contract? Would you say that's fair?
Yeah, I would say if you interpret sharing the data is simply a financial motivation for technologies like us, that's not the purpose. The purpose is to validate the efficacy of the system, and the only way we know what that validation is by you sharing it. I
agree, and there are protocols to do this. I think, though, it was getting intimated at that the folks were ignoring you, and as they listened to you, things could have been better. I think there might be some data that would need to be first before they entered into such a contract to prove that. Is that true?
Well, I think we have the data and the track record that actually does provide that and prove it. We're installed in more than 15 VA hospitals that we are able to work with. So we have history that can show.
Is this VA hospital handle it different than your other ones?
Mostly from lack of communications.
Okay. All right. Dr. Stout, Dr. Stout, you, again, some pretty strong statements. You said knowing the history of this VA. Could you tell me your history with that VA center?
I started to work at the Pittsburgh VA as a graduate student in 1980, and then I went on to be employed at the Pittsburgh VA starting in 1983, and my work there with Dr. Yu was to basically understand Legionnaire's disease transmission, prevention, not only at the Pittsburgh VA, but for healthcare facilities nationwide.
And I want to be clear that the research you've done is greatly appreciated. When I look up Legionella.org, it's you. And it's the two of you. So I want to be very clear on that, the work you've done there. I also want to be very clear, it's the 800-pound gorilla in the room. Is it safe to say there is some history between the two of you and the Pittsburgh VA?
Well, as was actually brought up by the chair, I believe, in 2006, and people probably don't know this, the chapter that then ensued happened because I had worked for the VA since 1983, and this is 2006, and never asked for a raise. When I asked for a raise after getting a master's degree, a PhD, and national prestige for the VA, the administrator said, give her a raise, and why do we even need the special pathogens laboratory? I think I'll close it and make Dr. Stout.
Is that on official record?
Yes, it's part of the testimony at
from 2008.
2008. And I also, just because Mr. Moreland brought it up, I want to share with the committee, you know, this is the result of the 2008 investigation, which showed clearly that our collection of isolates was a well-cataloged, very well-maintained.
So you dispute the comment?
Not a bunch of broken glass and
so you do dispute that point on the biobanking?
Absolutely, and I don't dispute it. The hearing proved that it was untrue, and I'm astonished that it was asserted here today. Amazing. It really calls into question the testimony of Mr. Moore.
Dr. Yu, how did you end your employment with the VA?
I was fired, and I was fired because they closed the special pathogens lab, but we had specimens that had to be processed, and they came from some of the most famous hospitals in the United States and public health agencies if they suspected an outbreak. And I said, you're closing it, but we've got all these that we're processing. So they said, stop processing them. And I wrote a letter to Specter and to Mr. Moreland. I had a choice between my conscience as a physician to process these samples that were being sent to look at outbreaks, or I could stop. So I processed them, and that was the reason I was fired.
Did you go through due process? Did you go to court over the firing?
It turns out that I'm a University of Pittsburgh professor with tenure, as many of the VA dean's hospitals are, and they said that I had no recourse. There is one anecdote that you'd be interested in. One of the specimens that we processed turned out to have Legionella, and it turned out they were having an outbreak. So we informed them that you have an outbreak. Your cultures are all positive for Legionella. And then because I was fired, because I processed those cultures, the healthcare facilities manager emailed me, because this had become national news, and thanked me for doing them this service, because they now recognized that the Legionella in their patients had come from that in the water, and that they recognized that I...
You know, as a layman, I have to tell you on this, and I say this not because I have any expertise on it, but because of the nature of it. I represent the Mayo Clinic area and have had numerous encounters with this. Biobanking is very complex. I had a critical access hospital that was nearly closed and went through 6 years of fights because a lab had a broken centrifuge and they carried it to another lab. The two of you know this is serious business. This is serious. The slightest breaks in protocol on biobanking are certainly reasons for recourse. Is that an untrue statement? That the biobanking...
I don't really follow your logic there. What are you talking about, breaks in... What do you... What can you explain?
This issue of saying that you process them afterwards. From a layman's perspective, I think there's great frustration. If we had samples here and said that they could have helped on this, how those samples are collected in the chain of custody of them and how they're done is so critically important. One lab test carried in a hospital from one lab to another broke the protocol of that and almost closed down the entire hospital because of contamination and all of those issues. So my question here is no one is denying the value of the research, but how the research is conducted is critically important. Is that correct? But am I wrong on that, Dr. Stowe?
Well, all I have to say is that after months of investigation, what the committee found, which is the Committee on Oversight and Investigation in Science and Technology, is that there was absolutely nothing wrong with the protocols that were being followed at the Pittsburgh VA and the Special Pathogens Laboratory.
So in recourse, then, I would have assumed that you would have gone to court to be right your wrong.
One of the things that I always say is that as an employee in the laboratory service, I was able to be represented by the union. Without representation of the union, I would have been fired without the ability to defend myself. With the union's help, I successfully defended myself against various accusations which were patently false.
Let me answer your question directly, because I think you're implying that maybe if we mislabeled something, left a tube out, hey, that's good enough reason to destroy the whole collection. Is that what you're saying? Because
I'm not saying it's good enough reason, but I'm saying there's protocols that, that those things are into effect, and right, and so, you both know that.
Yes, I agree with you.
That's a serious violation.
It's a serious violation. Dr. Melham said that that's the reason she destroyed it, and then she mentioned that in the televised hearing. But when she was deposed in a lawsuit, she said she never gave that order. It was done by 4 employees without her knowledge.
Okay. Well, Mr. Chairman, and I apologize for going down the road. The question I always have is of trying to find this. I think myself a sense of frustration that maybe a third person in this field maybe should have been here too, because there is a history, and that does not invalidate your testimony. It certainly does not invalidate the work that you've done. I think it brings into question, especially when strong accusations are made of criminal behavior, it brings into question the validity of that. And I think that undermines our ability to get at the heart of this. So thank you for your patience on that.
Let me just remind the witnesses and read from a little section that was sent to you. And it says, quote unquote, please be reminded that testimony requested pursuant to this invitation is governed by the applicable provisions of section 1001, 1505, and 1621 of Title 18 United States Code, which dictate penalties pertaining to submitting intentionally false statements to the committee or knowingly falsifying or concealing pertinent facts related to inquiries made by the committee. With that, I've got a few questions. Mr. Rothfuss. Okay. Mr. Shara, what is the remote monitoring system, or REAMS, and why is it important?
The remote monitoring system allows, if they're willing to tie it in, allows us to see minute by minute the activity of the individual computer and controller as to how much amperage, voltage, and GPM is, oh, I'm sorry, I keep doing that. How much amperage is required to maintain the targeted levels of copper and silver ionization. This is recorded, it's graphed, and documented all automatically with no intervention on the customer's part or our part, and it all goes to a website that collects the data, which is accessible to the individual customer, their infectious control personnel, their engineering staff, etc. So it just gives us another insight to really seeing what's going on in that environment of care.
Did the Pittsburgh VA have the remote monitoring system?
They had the capabilities. We had provided them with systems with the computer boards that was capable, but they chose not to connect them to a modem that would have allowed that remote monitoring access.
Ms. Dahl, have you experienced any retaliation related to your scheduled appearance here or in any other role at the Pittsburgh VA MC?
I haven't been retaliated for my testimony here today. Like I said, I won't know how people will respond until I return to my duty station.
Any intimidation?
I've been advised that I didn't have to come. I don't think I was in a mean way. It was just...
Were you encouraged not to come?
I was told I could be sick.
Really?
Yes,
And
sir.
who told you that?
The associate director,
Okay. When did they tell you that?
the Friday before I left.
Okay. Mr. Schwa, did your company provide training and written documentation to Pittsburgh VA personnel?
Yes, we did. Over probably easily 3 or 4 years with the institution of the newer model systems, and on-site training was provided to the various facilities people.
Okay. Ranking Member Kirkpatrick.
I yield back. Thank you, Mr. Chairman.
Thank you, Ranking Member. Mr. Murphy?
Thank you, Mr. Chairman. I'm curious for everyone who's worked at the VA hospital, and I go back to, I remember once being at a ceremony at VA Pittsburgh receiving some national recognition for its superb record of dealing with hospital-acquired infections, and I've talked to many people over the years, and it's helped me with learning and push for some legislative issues in terms of how to handle hospital-acquired infections and reduce them. It is a serious concern. I think it costs about 50,000 lives a year and maybe $100 billion or so. Or maybe have those numbers reversed. But let me ask this. Dr. Udep, when you were at the VA system in Pittsburgh, and what was the protocol when there was some infectious disease outbreak, MRSA or something else? Were staff generally notified when there was an infectious disease that was big?
Sure. The 30% rule wasn't that you just ignore everything.
I mean, with any infectious disease.
Yes, it's standard to certainly notify the staff because they're at the front lines.
And do you think that helped the VA develop a stellar record in terms of handling infections because staff were notified fairly quickly?
Yes.
And so that, like say anything like methicillin-resistant Staphylococcus aureus or central line infections or pneumonia, any communicable disease, how was staff usually notified when there was an outbreak?
Well, I was in charge of all of that when I was there, and we did it through a combination. I met with all the interns and residents because it's a teaching hospital, and the infection control practitioner met with all the nurses, and then we gave conferences. And then I rounded with the intensive care unit physicians because they handle the sickest patients. And we notified them of, you have to wash your hands, Legionella has come back into the water system, and so forth.
And other
very strong contact.
Well. Would this have been done within a week, a day, an hour? I mean, immediately?
Immediately.
Okay. And Ms. Dahl, for employees of the VA hospital system, are there standards also set in terms of notification timing of employees when there is an infectious disease outbreak that you might be aware of?
Yes, when we were we have protocols in place for things like the MRSA and things that there's screening tools that identify a person that they need isolation precautions. So then the staff use gowns and things of that sort. With the Legionella, again, I learned all my information from Googling OSHA guidelines as far as Legionella goes. And one of the things that they first said was that we should screen the employees that had been out for 6 weeks as soon as they noticed that there was an outbreak, which was 2 or more positive cases. So I immediately brought that to the attention of leadership because I was concerned that we weren't going to do that, and I was told that that would be a HIPAA violation to screen for that and send out letters. And I had argued that it was a Legionella outbreak and not a HIPAA violation.
We also notified the patients, and if they had Legionnaire's disease, all of them lived, so it was no big deal that you have Legionnaire's disease, we're treating you this. And we did that for MRSA patients as well.
Doctor, you just want to clarify something too. You said there was 0 Legionnaire's disease between 1997 and 2006?
1996 to 2001. There's in 2005, they have a 1 there, but we have a memo from the hospital director that says exactly the same years. That from the 10 years, there were none.
So with regard to my questioning regarding following protocol if there was an infectious disease outbreak, we've already heard testimony that when Legionella was discovered in the water system, medical staff were not immediately notified. Is that your experience, Ms. Dahl, that people were not notified?
Yes, sir.
And do you have any, what was that lapse of time between an official notification, not what you may have found on the internet, but an official notification and the others?
The first notification that I had as a local president was on the 16th of November, 2012, that there was a problem. We were going to water conservation. I received a call from the director.
And what was the date? Do you recall what the date was that they actually detected Legionella in the system then?
When I met with them on the 20th, the leadership at the VA to inquire about the situation with Legionella, I had asked, when did you first know that there were patients that were positive Legionella? And they had generally stated at least a couple weeks prior, earlier in the month.
Okay, I'm just trying to establish how much time between when the hospital knew and you were notified. We'll have to check that in the record too. Ms. Dahl, you mentioned that the associate director said to you that you could be sick today. Who is that associate director?
Her name is Levita Ford.
Was that a private meeting?
It was.
So no one else was present?
No, sir.
Any notes taken of that meeting? Any emails, anything else?
No.
All right. Thank you. I yield back.
Testimony today, and thank you very much. And this panel is concluded now. Excused. Let's see. The chair would now like to call Mr. Michael Moreland back to the witness table. Okay. Thank you, Mr. Moreland. Mr. Moreland, what is the training for Pittsburgh VA employees in running the sterilization system, and how much training was provided?
I really don't have the details on that. I know that they met with the vendor. I'm sorry, but I don't know the details of the exact minutes and time. I know that they met with the contractor to have an orientation to the system, but I don't have that at the tip of my tongue.
Are there supposed to be 2 FTE or full-time equivalent employees assigned at all times to run the system, as was stated? and how many were at Pittsburgh VAMC?
I know that the policy prior to its most recent talked about recommending 2 people, but the most recent policy, which I'll have to pull out and reference, requires 2 people to be there at all times.
And were there 2 people there at all times?
I don't know that for a fact.
So it really helped to have the people that we asked to be here to testify that would in fact have that information, would it not?
I can find that information for you, sir.
For the record? What was the reason for removing Dr. Stout?
Dr. Stout was not removed. She resigned.
And Dr. Yu?
Dr. Yu was, his services were no longer required because, as mentioned, he was doing work that was not authorized and not needed at the VA.
What is the VA's response to the fabrication of results?
I'm not aware, and I don't recall ever having seen any information about that. If there was concern that that occurred, it would have been my expectation that that would have been communicated to the VA Pittsburgh so that we could have taken action to address that concern.
Oh, Ranking Member Kirkpatrick?
I yield back my time.
Okay. You're dismissed. Thank you.
Thanks.
Anybody else? Concluding remarks? Oh, okay, yeah. Okay. Our thanks to the panel. VA Pittsburgh has been caught manipulating their own data to cover poor maintenance of the copper-silver system. VA has been caught intimidating its own employees, both those who wanted to convey information to their fellow employees about potential unsafe working conditions, as well as those testifying today. Make no mistake, the VA will be closely scrutinized for its actions towards those who have testified here today and towards employees who do the right things. Furthermore, there has been a serious breakdown in how the VA assessed its responsibility in diagnosing and reporting Legionella. There was a dismal failure in the VA following its own policy and CDC guidance in addressing Legionella. There was a tragic failure in leadership at the local level, the VISN level, and at the VA central office level. And in the end, 5 veterans died. 5 veterans died that we know of, and others, both veterans and employees, became very ill. This hearing was necessary in order to accomplish a number of items. 1, there must be an accounting for the failures that have been identified through hard evidence. 2, the VA Central Office needs to strengthen the inherent weakness of the Infection Control Program Office, thoroughly reviewing the reports and plans from well-performing facilities and applying those practices elsewhere. 3, there needs to be a unified focus from CDC, the VA, and other organizations to ensure everyone knows what to do, everyone can be held accountable, and that this travesty never happens again. 4, within 30 days, I expect the VA to contact my subcommittee staff in a bipartisan fashion. We will chart out a road ahead. With that, this hearing is adjourned.